All right, now we'll start the meeting with a little technology. Good morning, everyone. I have to say that I'm really glad that we're in this meeting room on Wednesday morning or together virtually. And thank goodness that everything aligned that we could have this meeting today and that all of our federal employees are funded in their activity. We greatly appreciate that. For those of you who don't know me, I'm Susan Winkler, and I have the privilege of serving as the Chief Executive Officer at the Reagan-Udall Foundation for the FDA. If you've never heard those words in that order before, here's the explanation. We are the nonprofit, non-government organization created by Congress to help the Food and Drug Administration do more to protect and promote the public health. And we are privileged to work on a number of projects with the agency, including a whole suite of projects related to substance use disorder. So thank you for joining us. We are working with the U.S. Food and Drug Administration today to host this event. To explore the real world evidence and experience with the presence of xylazine in the non-medical drug supply. So I say thank you to all of you who are in the room here and to the hundreds who are in the room virtually who have joined us to also learn more today about xylazine. So before we begin, I have to do the housekeeping issues. As a reminder, it is a hybrid event. We'll remind the folks who are online that they are muted and their video will remain off during the meeting. If you are in the room here, it's easier if you don't log into the Zoom because it can create feedback. So enjoy the experience of being here in real life. We will record the public meeting, and that recording has already started. The recording will be posted on the Foundation's website at the conclusion of the meeting, along with a transcript. The slides and a bio packet and an agenda are all available online for our virtual attendees to take a look at. For our in-person folks, just some logistics. Restrooms are out the hallway and to the left. And then a logistic for all of us at 2:20 p.m. Eastern Time. If you've read in the news, there will be a test of the emergency broadcast system. So we are going to experience that together. We don't know exactly what that will mean, how long it will last, and what it will do to our eardrums, but we'll just work through it. It happens to be at the start of one of our sessions, so we will kick that off in earnest after we finish that test of the emergency broadcast system. There is also a Wi-Fi password. If we could go back one slide, there is a Wi-Fi password for those of you who are here in the room. If we go back one, it should show. Nope, it was on the housekeeping slide. So that Wi-Fi is Reagan-Udall 2023, if I remembered things correctly, with a capital R. We will make sure that you see it. So let's talk a little bit about the agenda for our meeting. And I want to encourage you, there we go. There's the Wi-Fi access password at the bottom of that slide. So for those of you in the meeting, you do have to spell Reagan correctly. So it would be R-E-A-G-A-N Udall 2023. That's just a little test for you if you're here in the room to get you into the Wi-Fi. So let me encourage you both here in the room and online to submit your questions. I'm going to walk us through the agenda so you have a sense of what it is that we're going to be talking about today, but we will all learn more if you give voice to your questions and we get to pursue different lines of interest. So please, if you're in the room, I will bring the microphone to you and I can either say your question for you or you can say it right into the microphone. If you're virtual, if you drop it into the chat, then I will pick that up and aspire to give voice to it. So let's talk about that agenda. In just a minute, I am going to turn the stage over for opening remarks to Dr. David Holtgrave from the White House Office of National Drug Control Policy, and then to Dr. Marta Sokolowska from FDA for opening remarks. Then we're going to move through a series of sessions to hear about the xylazine landscape, including epidemiological trends, latest research, product needs and product development, and on-the-ground response. And then at the end of the day, take time to reflect and say, okay, here's where we think we're going to go to pursue activity to respond to human exposure to xylazine, and how might that have changed based on what we heard and shared today, so that we can collectively say, all right, where is it that we should go? We do have a break in the middle of the meeting, so we'll have a full hour that you can catch up on email, stretch your legs, go grab lunch. And then, as we said, we'll have our unanticipated but celebratory break at 2:20 p.m. I will remind you again of that interruption as we get there, and then we will know what it is that's happening. So back to items that are within our control. As I mentioned, there are a number of materials on the Foundation's website to support your engagement in the meeting, and here in the room, you should have all of the materials that you need. With that, Dr. Holtgrave, would you join us on the podium here? You serve as the Assistant Director for the Office of the National Drug Control Policy, and just help us get this meeting started.
So many old acquaintances and colleagues. So thank you for having us. And I look forward to these very important discussions today. To give a little bit of an overview around xylazine, as you may well know, the 2018 Support Act affords the White House Office of National Drug Control Policy Director the authority to declare a new substance or pattern of use to be an emerging threat if so warranted. And in January of 2023, ONDCP published explicit criteria for what might be considered an emerging threat, namely a spread to at least 3 of the 4 census regions in the US and an increase of at least 15% in a key metric, usually drug poisonings. On April 12th of this year, under the authority granted by Congress and based on data showing severe morbidity and mortality consequences of fentanyl adulterated with xylazine, ONDCP Director Gupta designated fentanyl adulterated or associated with xylazine as an emerging threat facing the nation. This marked the first time in our nation's history that a substance was being designated as an emerging threat by any administration. And on July 11th, 2023, Dr. Gupta announced the White House's new National Response Plan to coordinate a whole of government response to this threat. And now, before I go into more detail on that response plan, let me briefly touch base on why ONDCP designated this emerging threat in the first place. As this group is very well aware, given your work, xylazine is a non-opioid tranquilizer for veterinary use that was never approved for human use. It's being increasingly found in the drug supply, particularly mixed with fentanyl. The xylazine itself slows breathing and heart rate to unsafe levels and complicates efforts to reverse opioid overdoses with medications like naloxone. But of course, we want to stress that opioid reversal agents like naloxone should still be used regardless. Xylazine is associated with deep flesh wounds in some persons that may require extensive medical intervention. And these wounds are often independent of injection sites, may be a challenge to treat, and they're carrying a special kind of stigma. Today, xylazine has been detected in nearly every state in the US, according to the DEA. And CDC recently reported that the monthly percentage of illicit fentanyl overdose deaths involving xylazine increased by 276% between January of 2019 and June of 22. In other words, xylazine is involved in nearly 1 out of every 9 overdose deaths involving illicit fentanyl. So what we do next matters. The response plan that was released in July outlines the actions that the administration will take to protect public health and safety and save lives. Over the last several months, several departments from HHS to DOJ to the VA to Commerce to DOT, the State Department, DHS, and others have regularly been meeting to chart out an evidence-based, data-driven approach and way forward. And this is reflected in the xylazine response plan that I mentioned. In that plan, there's 6 pillars of action, and I'll briefly mention each. The first is testing. Testing for xylazine is currently clearly ongoing in many communities, law enforcement settings, but not enough. We need more testing to get an even better and more refined national picture of the threat. So the federal government will work toward standardizing forensic testing practices, toward developing new tests for clinical settings, toward deploying testing in community settings, as well as targeting testing to communities most in need. Secondly, we need to expand our data collection. We need even better data and more comprehensive data to see the full picture of this threat and to inform our comprehensive response. And of course, more comprehensive data will help us better evaluate our efforts and adjust course if necessary. The third pillar is implementing and expanding evidence-based prevention, harm reduction, and treatment for xylazine. The fact is that right now, the medical community knows how xylazine adulterated fentanyl affects individuals, but there's not one single agreed upon framework for providing treatment. So we're developing that treatment framework, and conversations like today are incredibly important for informing that discussion, as well as overdose prevention and other harm reduction strategies for those in community, in carceral settings, as well as in healthcare settings. And we want to provide the capacity to support healthcare providers, harm reduction professionals, health sector payers, as well as first responders on best practices to help treat flesh wounds. Next, we want to continue to determine where xylazine is coming from. Many of you in this room probably saw that on September 22nd, DEA and DHS issued a joint statement which read, DEA and DHS have identified xylazine intended for illicit human use entering the U.S. in several ways, in solid form from China and other countries, in liquid form either diverted from veterinary supply chains or packaged to resemble a veterinary drug, and to a lesser degree mixed with fentanyl seized at the southwest border. So now we also have to get further information in this regard and develop interventions to better interdict illicit xylazine supply. Fifth, we want to continue to explore conversations such as the independent process between FDA and DEA about scheduling. And as all of you know, I'm sure there's a lot of congressional interest right now in xylazine-related issues as well. So regulatory issues like scheduling are certainly topics of conversation. And at the same time, one must figure out how to maintain the legitimate supply of xylazine for the important uses in veterinary medicine. And finally, our last pillar is research. We need to know more about fentanyl combined with xylazine and need to look even more in detail at topics like developing effective treatments, investigating how xylazine impacts human physiology and behavior, and identifying social determinants of health related to xylazine. So we want to move forward as quickly as possible to implement this response plan. And in fact, Dr. Gupta directed federal agencies to develop implementation plans by September 11th. Those were submitted and now are in the process of being cleared, and we will be summarizing those as quickly as we possibly can. The good news is, though, that we're not just waiting for plans to be written. Many of the actions that I've touched on today already have examples of work that's ongoing. For instance, in February, the FDA took action to restrict the unlawful entry of xylazine into the country. In June, NIDA had an important meeting on evolving practices in wound care and drug treatment. NIDA has also issued a notice of special interest on xylazine-related research. CDC has published a number of papers on xylazine-related epidemiology, and their website is continually updating information on this emerging threat. And in March, DEA issued a public safety alert to warn Americans about a sharp increase in the trafficking of fentanyl combined with xylazine. And we're also working hard to evaluate pathways to make sure that xylazine test strips are available to those who need them, and grantees interested in this issue should speak with their project officers for further information. The response plan also sets ambitious goals. At the top of that list is seeing at least a 15% reduction of xylazine-positive drug poisoning deaths in at least 3 of 4 U.S. Census regions by 2025. And to achieve this, we need to mount a whole of society effort to save lives. We want to make sure that by 2025, as fentanyl adulterated with xylazine is no longer an emerging threat. We hope it's not even a continuing threat, but we have to set an ambitious goal to make sure that we address this important public health challenge. And so we're calling on everyone at this meeting to be a part of the solution, as your work already is, to take even further action and to work with us to stop this emerging threat and save lives. Because working together, we can address this challenge. And the response plan itself can be found on the ONDCP website in the briefing room tab. And as always, we welcome your feedback, suggestions, and thoughts about the response plan or other aspects in this important area. Thank you very much, and we look forward to the conversation today. And with that, I'll turn it over to Susan.
Great. Thank you so much, Dr. Holtgrave. I think you've challenged us to work together. And it's just so lovely to have in-person applause. Thank you. We'll keep that up for each of the speakers. But to be thinking about the plan and the pillars and what work we can do today to help advance all of that collaborative effort. Excellent. Thank you so much. So we'll turn the podium over now to our second opening speaker. So please welcome Dr. Marta Sokolowska, who is the Deputy Center Director for Substance Use and Behavioral Health at FDA's Center for Drug Evaluation and Research. She's been the agency's primary sponsor for this event, and we're just thrilled, as we said, to be here. And Marta, please take the microphone.
Well, first of all, good morning to everyone. So great to see people in person, not just squares on the screen, but good morning to those on the screens as well, and welcome. Let me begin by thanking Reagan-Udall Foundation for putting together this important meeting and your commitment to make this event an actionable piece of our overarching strategy to address this very important crisis that we need to address. I also would like to thank our federal research and community partners for your commitment to have data-driven discussions how to best address this problem. Without you, we wouldn't be able to make progress. So again, thank you very much for your commitment. To begin with, I would like to start with highlighting the FDA overarching overdose prevention strategy or framework. This framework was initiated in August of 2021. And as part of the framework, we identified 4 priorities, how we want to address the overdose crisis, which is guiding our vision and our implementation strategy. So it focuses on 4 pillars. First is primary prevention. We are focusing on eliminating unnecessary initial prescription, drug exposure, and inappropriate prolonged prescribing. Number 2, we are encouraging harm reduction efforts through innovation and education. 3, advancing development of evidence-based treatments for substance use disorder. And 4, protecting public from unapproved, diverted, and counterfeit drugs presenting overdose risks. I'm sure you're well aware, xylazine is an active ingredient in the FDA-approved drug products that is not approved for human use. And it's the crisis very much fits into our overdose prevention framework, trying to address this issue. I'm sure you are also aware, as Dr. David has mentioned earlier, is that we have this emerging crisis of people being exposed to xylazine despite the fact that it's not approved for human use, predominantly by being presented in combination with illicitly manufactured opiates. As an agency, we understand that xylazine opiate drug combinations are associated with significant and negative health consequences. And as part of our action, FDA took steps to inform healthcare providers about the risks to patients exposed to xylazine and illicit drugs, for example, through our letter sent to healthcare professionals in November of last year. We have also issued an import alert in February of 2023 to restrict unlawful import of xylazine while maintaining xylazine availability for legitimate animal use, which is also a very important part. As Dr. Holdgrave has indicated, ONDCP, across with collaboration with other governmental agencies, came up with a fairly elaborate plan to address this this overdose crisis, this emerging drug threat. FDA is part of this initiative, and we have a number of strategies that we are working on implementing from FDA perspective, and we are hoping that is going to have impact on this crisis. For instance, we collaborate with federal agencies and other interested partners to help ensure that testing is targeted for those in need. We focus resources on source and supply intelligence, including effective supply chain investigations and engagement of foreign regulators as appropriate. We engage with other agencies to coordinate data-driven approaches to interdiction efforts and raising the public's awareness of potential products containing fentanyl and xylazine in the marketplace. And we conduct basic and applied research on the metabolism of xylazine and support drug development for treatment of xylazine overdose and withdrawal. As a reminder, during this workshop, we will collectively strive to outline our understanding of the current landscape of xylazine and similar drug compounds in the US, including changes in the patterns of use, trends in the illicit drug supply, and real-world experience of overdose. We identify specific areas of exploratory research that can be used to mitigate risks associated with human xylazine exposure, and discuss existing data gaps and specific strategies for improving current surveillance systems. Today, we look forward to advancing innovative and diverse activities that will help narrow knowledge gaps and drive solutions to address growing negative impact that xylazine is having on our communities. We look forward to being involved in today's activities throughout the day. And we are really encouraging you both online and here in person to really have a robust discussion that will help us to lead to very actionable results and actionable solutions that can be implemented shortly. In closing, I just want to reiterate our deep commitment to addressing the critical issue of xylazine and the illicit drug supply. And it's clear that this problem demands collaborative, all-hands approach. And today's discussion is just another step in the solution, coming up with a solution to this problem. So with that, I just want to say thank you and looking forward to the discussion.
Fabulous. Let's thank Dr. Sokolowska. So with those stage-setting remarks, it's time to get into the substance. So if you are not fully caffeinated and need some more, now is a good time to kick that off, because we are going to get into an overview and look at the current trends in xylazine overdose morbidity and mortality and the geographic distribution of xylazine in the non-medical drug supply. We're going to kick that off with our first virtual presenter. So this will also be our first audio-visual check of bringing in we were going to bring into the physical room and into the virtual room Dr. Jean Coe, who serves as Deputy Director of Scientific Programs in the Division of Overdose Prevention at CDC's National Center for Injury Prevention and Control. So Dr. Coe, I think you're online and ready to join us. We're going to pull you up on screen here and look forward to hearing your remarks. Great, we can see you. Go ahead.
Good morning, everyone. Thank you for the invitation to speak today. Next slide, please. Next slide. So just a general disclaimer, and I have no disclosures to note. Next slide. Great, thank you. So xylazine is a non-opioid sedative that is not approved for use in humans. There is no clinically proven effective antidote, and it is known by several alternative names listed on this slide. And it was first identified in Puerto Rico in the early 2000s as an adulterant. Next slide, please. An adulterant is a pharmacologically active substance that is added to a product intentionally to increase bulk, enhance or mimic a pharmacologic effect, or facilitate drug delivery. Next slide. Clinical presentations in humans may include central nervous system depression, dizziness, respiratory depression, apnea or shallow breathing, and hypotension, for example. Chronic use might lead to severe withdrawal symptoms as well as skin ulcerations, as you had heard earlier today in the opening remarks. Next slide. Xylazine has been in the news. It has been increasingly detected in illicitly manufactured fentanyl or IMF products in the US drug supply and in IMF-involved overdose deaths. In April of 2023, the White House Office of National Drug Control Policy designated fentanyl combined with xylazine as an emerging threat in the US. Next slide. In 2022, provisional data indicated that over 2/3 of the reported 100,000 plus drug overdose deaths in the United States involved synthetic opioids other than methadone, primarily illicitly manufactured fentanyls, IMF. So we sought to understand whether there is an increased presence of xylazine in IMF drug overdose deaths and the geographic distribution of IMF-involved overdoses with xylazine detected. So the next few slides, I'll be presenting data from a report that we released in June of this year. Next slide. So we used data from the State Unintentional Drug Overdose Reporting System, or otherwise known as SUDRS. SUDRS is part of CDC's Overdose Data to Action program. This map shows the jurisdictions participating in SUDRS during the 2019 to 2023 cycle. Next slide. SUDRS combines death certificate, medical examiner, coroner report, and postmortem toxicology results to include demographic, circumstance, overdose risk factors, comorbidities, and contributing drug data. Next slide. Using SUDRS, we examined trends of IMF-involved deaths among 21 jurisdictions, so 20 states and DC, with complete data over a 3-year timeframe, January 2019 to June 2022. Additionally, among 32 jurisdictions, so 31 states and DC, with complete January 2021 data to June 2022 data, we compared characteristics of IMF-involved deaths with and without xylazine detected. We also mapped IMF-involved deaths by xylazine detection or co-involvement. Next slide, please. So among the 21 jurisdictions that had data from January 2019 to June 2022, we found that the monthly percentage of IMF-involved deaths with xylazine detected increased 276%, from 2.9% in January of 2019 to 10.9% in June of 2022. This figure shows the increase in number and percentage of IMF-involved deaths with xylazine detected in the solid line and the dotted line. And the dashed line displays the number of IMF-involved deaths with xylazine co-involved. A drug was considered involved or co-involved if it was listed as a cause of death on the death certificate or in the medical examiner or coroner report. Next slide. During January 2021 through June 2022, in 32 jurisdictions, xylazine was detected in 9.0% of IMF-involved deaths and co-involved in 6.9%. Next slide. Xylazine detection varied by jurisdiction and was highest in the Northeast, as shown in this map. Next slide. And the percentage of deaths that were male and female were similar among IMF-involved deaths with and without xylazine detected. Next slide. Race ethnicity, shown on this slide, also was similar among IMF-involved deaths with and without xylazine detected. Next slide. And co-occurring drugs listed as a cause of death was also similar among IMF-involved deaths with and without xylazine detected. Cocaine and methamphetamine were the most common drugs listed. Next slide. So overdose circumstances were also largely similar, with the exception of a lower percentage of IMF-involved deaths was xylazine detected having evidence of no pulse when first responders arrived, so 53.3% versus 62.2%. Next slide. And a higher percentage of IMF-involved deaths with xylazine detected had evidence of injection drug use, so 28.6% versus 19.5%, as seen on the left-hand side of the slide. Next slide. So a few limitations to note related to these analyses. These analyses are not nationally representative, and so the results may not be generalizable. Additionally, toxicology testing of xylazine was not uniform across jurisdictions or over time, likely leading to an underestimate of the true prevalence of xylazine in overdose deaths. Next slide. However, we do have some public health implications that we can draw from these results. Naloxone should be administered to reverse effects of opioids, even if xylazine is suspected to be present, because xylazine is often found in IMF products. Additionally, supportive care is critical in the event of overdose involving xylazine. Next slide. Xylazine prevalence may be underestimated due to the variability in testing frequency across the US, as I mentioned earlier. Certainly, implementation of routine standardized toxicology testing for xylazine may help us improve surveillance related to xylazine and understand the role of it in overdose mortality and morbidity risk. Next slide. And just pointing out a few additional strategies that communities can use to reduce harms of xylazine and opioids versus as well as fentanyl mixed with xylazine. As mentioned earlier, including naloxone administration is important in overdoses with xylazine suspected, as well as linking people with care who are at risk for overdose and educating the public with the increasing prevalence of xylazine detections. Next slide, please. Finally, I'd like to acknowledge our CDC Division of Overdose Prevention staff, specifically the Mortality and Data Management team in the Epidemiology and Surveillance branch, as well as our jurisdictional partners participating in OD2A. Next slide. Thank you so much.
Dr. Ko, thank you. And Dr. Ko, I have one question for you before you go, and we're going to have you back at the end to join our full Q&A session. But this was a question specific to suitors. And I'm not sure if we understood it correctly, but one of the folks asked whether suitors includes information from Puerto Rico or not. And if you don't know that, that's okay. We can maybe come back and answer that in the Q&A session at the end. Would that work, Dr. Ko? Yeah? Or you're looking? All right. Actually, I'm gonna, yeah, go ahead.
Sorry, I was trying to unmute myself. Yes, I can confirm at the end of the session at the Q&A.
Perfect. Then we have our first question lined up for our Q&A session. So thank you, Dr. Ko, for the perspective from the CDC. We're now going to turn to another really important source of information, which is more from the law enforcement perspective. And we are fortunate to have two speakers with us today. So thank you for filling both of our podiums in the room. We're going to hear from Amanda DeStefano, who is an intelligence analyst, and Drug Intelligence Officer Van Jackson, who are both joining us from the Liberty Mid-Atlantic High-Intensity Drug Trafficking Area. And I know you'll do this, but Amanda and Van, remind us what the Liberty HITA is. If I am butchering the abbreviation, but you're going to teach me that in just a minute.
Yes, we are.
All right, the podium is yours.
Thank you. All right, good morning, everybody. Thank you for having us. As Susan said, I'm Amanda DeStefano. I have my colleague Van Jackson here. I'm an intelligence analyst for Liberty Mid-Atlantic HITA. Van is our drug intelligence officer. We're kind of going to give you the law enforcement perspective on what we're seeing, especially given the fact that we were labeled as the epicenter being in Philadelphia. So I'll give you that background and let you know how we've been tackling this issue. Next slide, please. So kind of as Susan alluded to, we are the Liberty Mid-Atlantic HIDA. HIDA stands for the High Intensity Drug Trafficking Area. We are funded through the Office of National Drug Control Policy. We are a program, not an agency, but we are a collaboration of various federal, state, local, and tribal agencies. Our office works with over 24 different initiatives in the Philadelphia, New Jersey, and Delaware region. I myself am part of the ISC, which is our Investigative Support Center. So it's a group of analysts doing investigative support for various cases in the area. And then my primary role is the monitoring of the drug trends and other related activity in the area.
And I'm a member of, as far as our initiative is overdose response strategy. So in all the HIDAs, we have a partnership with public health and public safety. So my position is usually retired law enforcement, and the public health analysts are members assigned to various departments of health for the state. My partner, Tamar Wallace, is assigned and works in conjunction with the Pennsylvania Department of Health. And so we come up with strategies and far as taking law enforcement information and intelligence from the cities and the state and to feed it to the public health to come up with programs and evidence-based initiatives to treat the overdose criteria in our state. Next slide, please. Designated in 1995, HIDA started, it was just Philadelphia and Camden counties. As you see, we have spread it to 11 counties now, 5 in Pennsylvania, 5 in New Jersey, and 1 in Delaware. So we are in the middle of the epicenter, and the bleed over for xylazine is also in Camden County in southern New Jersey. So since we're state bound as drug intelligence officers, I work with my other drug intelligence officers in New Jersey and in Delaware on this problem also, and they deal with their state governments, and we come up with plans to and get intelligence to deal with this the crisis of xylazine and intelligence as far as working with our drug units in each HIDA to deal with illicit dealings of xylazine. Next slide. Xylazine in Philadelphia, as the doctor mentioned earlier, first detected in Puerto Rico as the main epicenter. We first detected in Philadelphia in 2006 from the medical examiner's office in the Philadelphia Department of Health. Alerted us to this problem I first heard when I became in this position, 2018. So an analyst for Philadelphia PD explained what xylazine was, because I first came, we had a meeting for intelligence meetings. He said there's this new drug xylazine we're seeing in Philadelphia in the drug supply. And that's when the switch over from heroin to fentanyl was increasing. So therefore, from the MEs and the lab reports that we got from Philadelphia Police Department, I alerted to the HIDA initiatives and my other drug intelligence officers in the other states. So we came up with plans before when drug units were doing search warrants at houses, they found the powder, but they did not know it was xylazine. They just thought it was another adulterant mixing with cocaine and heroin at the time. But due to the intelligence, I explained to them that, no, it's xylazine. I need you to start documenting the xylazine, sending it to the Philadelphia and the state police labs and asked to test for xylazine so we could see the amount of the presence in the drug supply at that time in 2018. And as you see by all the stats, it has grown immensely. And in other counties in Pennsylvania, when I alerted my partner, Tamar Wallace, she queried the other counties in Pennsylvania about it to start testing, because the main thing was people weren't tested for xylazine. So once we spread the intel on that, like I said, it ended up being a 90% of the street opioid samples. So as we had down here, fiscal year 2023, CBP sees 12 kilograms destined for Philadelphia from China coming in due to the FDA request at the border. So CBP has done a great job entering the xylazine coming in, the illicit non-prescription. And also we've seen the destined from Philadelphia, from the Dominican Republic. And from my colleague, the drug intelligence officer in Puerto Rico has alluded that a lot of xylazine comes in from the Dominican Republic, that they seize it all the time in Puerto Rico. Next slide.
All right, so this data is from a partnership with the Philadelphia Department of Public Health and NMS Labs in Willow Grove, Pennsylvania, and actually from my wonderful friend Alex, who is here today. We've been kind of going back and forth about the data because one of the challenges that we've had in Philadelphia was that the labs haven't been testing for it unless it was special request, as Van said, or it came as like a bulk seizure. Like for the Philly lab data, we only have about 2 months. They've only been testing for it and logging it since about June. So I've been working with NMS Labs with this for many months now. You can see in 2022 that 90% or 91% of the fentanyl samples contain xylazine, which then increased in 2023 to 99%. So pretty much almost all of the fentanyl samples that they had tested had xylazine, and these are surrendered samples of powder from the streets of Philadelphia. And then as you can see, the average purity of xylazine in these samples has also been increasing about 35% up to 39%. And this data is not complete for 2023, obviously. So I imagine that that number will probably go up as the data comes in. And additionally, the Delaware Forensic Lab sends their data to us monthly as well. And the ratios of xylazine to fentanyl that they've been seeing was upwards of 55-1 earlier this year. And that has just continued to rise as the year has gone on. So from LMA HIDA, kind of how we began to tackle this earlier this year, prior to scheduling, we were actually, we initiated the first data collection because no one was testing for it in the area due to the legislation at the time. So we kind of had an isolated email thread that was received pretty well by various agencies in the area to send in the lot numbers that were on the boxes that the vials were in at the time when it was liquid that we were seeing. So, you know, we began to track the lot numbers and we thought we were really onto something because each one of these lot numbers was like thousands of bottles of xylazine. So if we were able to track this back, we were like, yeah, this is going to be like a really big win. And kind of what we were finding on the streets of Philly was that by the time the seizures were happening, the vials were not with their boxes anymore. So, you know, whether it was after transport and things like that, they were just thrown in the houses and things like that. So we did get, you know, a good amount of lot numbers, and we were able to track with help of DEA and FDA. We met with everybody in Philly earlier this year. We were able to track it back to a vet supply in Florida. So that's kind of where we were tracking the domestic shipment of these bottles. And however, very quickly, we transitioned from the vials to seeing it in powder form. So, you know, the cost of the vials we were finding on the street was like $100 to $300 a vial through various online vendors from China and shipped right through the mail. People were able to get kilos of the xylazine powder for like $6 to $20 a kilo. So it's not surprising to any of us that the shift from vials to powder happened, and it really kind of happened overnight. So I'm gonna turn it over to Van, who's gonna kind of talk about how we were conducting controlled deliveries of the xylazine because they were also leading us to fentanyl mills.
And as she explained, far as checking the parcels, far as UPS, US Mail, and FedEx. So the law enforcement was keen to that and start seizing it at those facilities. And what we try to do is control delivery, because early on we learned that it would go to heroin or fentanyl mills. So even though it wasn't scheduled, we would try to get search warrants. Some people out the box, some investigators, to get search warrants for paraphernalia, since it wasn't scheduled and you couldn't arrest for the xylazine. So that led to Philly PD and state police units and Homeland Security and DEA agencies getting search warrants for these mills, because you know the xylazine will lead you to the fentanyl, and that's where they were getting seizures. As you can see, this investigation led to federal convictions of 20 years, and so that was the main just as far as investigating the xylazine. Now, as it transcends with the scheduling, they now look for xylazine dealers. So now it's being sold in the big buckets. So now they target the dealers of selling xylazine, since they can arrest for that to try to curtail that. But like you said, all the search warrants for houses, they're seeing xylazine. And so that's, we're trying to pick up that portion of investigations into the dealers, into the trafficking, into the country. Next slide.
So now that it's scheduled and we can actually conduct enforcement operations on xylazine, we are doing that, but kind of our perspective on this is that it's still, the fentanyl problem is still the main issue for us on the law enforcement end. And so if you look at this graph, it's up through 2022 from the Pennsylvania Office of Drug Surveillance and Misuse Prevention. So xylazine is the red line on this, showing the trends in the most common drugs contributing to deaths in our area in Philadelphia. And while xylazine is noted as a contributing cause of death, you could see here that opioid stimulants, cocaine, et cetera, are still higher, contributing to overdose deaths at a higher rate than xylazine is in our area. So while the knowledge and understanding of the effects of xylazine in our area are important, we're seeing data like this that's showing how imperative it is to kind of continue focusing on fentanyl and the analogs and other substances in the fight towards this opioid epidemic. And just as an outlook for us, detections of xylazine in drug exhibits and overdose-related toxicology are going to likely continue as the labs are implementing testing and logging. I imagine the numbers for Philadelphia are definitely underreported, given that we only have 2 months worth of data for this year. As states continue to add xylazine to the list of scheduled drugs, alternatives to xylazine will likely appear. The DEA put out a report last week. We've already been seeing it in our drug supply, things like medetomidine and dexmedetomidine. So that's going to become a challenge for us as the turnover continues, to kind of keep policing that. And really, xylazine is being used as an adulterant like many other substances are. So it's important to keep the focus on fentanyl and other substances that are driving this opioid epidemic. But, on the front lines, on the streets, we continue to tell our officers to administer naloxone, use proper personal protective equipment, know the signs of an overdose regardless of what substance is causing the overdose, and just reinforce those response measures when identifying those experienced overdoses.
All right, so let's thank our speakers from the Liberty Atlantic HIDA. And I'll just note, Amanda and Van will have you back for the Q&A at the end of this session. But I think you underscored it's really important that we gather information from a number of sources about the emergence of xylazine and then other adulterants. And as you just noted, Amanda, that we also keep our eye on fentanyl and those products that are having the most immediate human harm. So thank you for helping us learn more on the xylazine presence in the supply itself. And we will see you back at the Q&A session.
Thank you.
So we'll turn now. We are going to turn to our next speaker and hear from Dr. Tracy Green, giving us yet another perspective about the risks of human xylazine exposure and how we might mitigate some of those. I will say keep the questions coming in on the chat as well as in the room. I'll turn to you if you'd like to raise your hand, but I have a lot in the queue for everyone. With that, Dr. Green, would you share what you have learned and discovered from your work at the Opioid Policy Research Collaborative at Brandeis?
Thank you. I'd be honored to. Thank you for the invitation to come and talk with you today about what we've been doing in Massachusetts. So the next slide. To introduce, you've seen some of the national data to reflect that because we don't know that there's a human safe consumption, but xylazine continues to increasingly be found in the drug supply. Long seen in Puerto Rico, evidence from death records and drug seizure data like you've been seeing. In Rhode Island, where I first met a recent decedent case in 2015 involving xylazine. Connecticut and New Jersey all placed xylazine there from the 2000s onwards, but a really a quite uncommon instance. More recently, those shifts, especially in the Philadelphia area, heroin and fentanyl overdose, the most recent studies detected less than 2% in overdoses between 2010 and 2015, but a shift very quickly to 2019 and appearing in 31%. And those most recent data show that more, as you've seen, more than 90% of the heroin samples or suspected heroin samples also contain xylazine. Last month, Millennium Health Signals Report, a urine drug screen-based study released last month, showed that xylazine was detected throughout the country, but concentrated in our neck of the woods, mostly in the Mid-Atlantic and the eastern north central areas. So the next slide. When we look to Massachusetts, we've been seeing the drug supply shift to involve xylazine very recently as well. And this is because we have invested in and expanded community drug checking. So this work is coordinated by a team, our team, and we call it the Massachusetts Drug Supply Data Stream. And we've been detecting xylazine progressively in higher proportions since 2020. And now to over a third of our opioid samples in 2022 and 2023 contain xylazine. And so since that first initial health bulletin, because we'd been seeing xylazine early on in March 2021, we were able to inform our community and our healthcare providers about the veterinary sedative and some of the concerning use experiences that people were sharing about. We could also identify the form in which it was emerging and could clarify whether it was pill or powder, and in what ways that it was being sold or expected to be. So that was fentanyl and heroin. So you can see on the left-hand side some of the data from year to year, with showing rises in the prevalence of xylazine. And on the right is an example of the alert that we were able to release more recently in the 7 languages dominant in Massachusetts, informing people in plain language about more of the concerns related to xylazine's presence in the drug supply, as we were able to pull together from our data. The next slide. Just so that we know what we're talking about, community drug checking in Massachusetts takes the form in 16 sites as being first and foremost placed within a harm reduction program, and in collaboration with, or at least in support of, the district attorney or the police department in that jurisdiction. Individuals from the community can provide samples, remnant samples for testing, where they are collected in the course of harm reduction activities through a range of opportunities, and those are tested. The next slide. They are tested through a series of both point of care testing opportunities with test strips like we've been talking about, as well as with FTIR, or Fourier transform infrared spectrometers, that are available at the community site. So that occurs at the point of care within a matter of seconds to minutes. And then the samples are sent to laboratory for additional testing, because the limit of detection is not, it doesn't see below 5% weight for many of our components. So GCMS and LCQ2F testing is done by a range of labs, and then medical toxicological consultation occurs at those combinations or in the form, because as we know, xylazine and injection or oral, anal, snorting, inhalation, these are routes of administration that are not, have not been expected and been studied in animals. So the next slide. These data are all compiled publicly on a website that we maintain called streetcheck.org, with public-facing trends and sample-level data. And those are the places as well as on a secured backend where the programs can see at their local levels what is happening in their particular program, and share that information back with their client participants, as well as with their local task forces or other activities that might be networking to respond more immediately to the needs that are going on. So this is a SAMHSA, CDC, and state-funded effort. The next slide. So community drug checking, to be clear, really refines our response capacity. And that is because across a range of devices, we can collect qualitative, that is absence or presence, semi-quantitative, that is ratios or categorically major, minor, or trace components of the drug, as well as quantitative, or a percent component breakdown. And each of those can help us answer different kinds of questions that are important for people who use drugs, for community members who are responding and supporting people who use drugs, and for our collective public public health and responses. So we've already answered the question of how common is xylazine in the drug supply directly from our community drug checking programming work. The second question, relative to fill in the blank, and here we'll talk about fentanyl, is there more xylazine in the drug supply? And the third question of what percent of a drug sample does xylazine compose, and how much xylazine is in a given drug sample? Paraphrase there. Each of those we're going to talk about next. So the next slide. So from our data, xylazine to fentanyl ratios have been shifting. Over those same time periods where the prevalence in the general drug supply of opioids has increased, so too has the amount or the ratio of xylazine to fentanyl. So we're getting a larger dose of xylazine over time in our communities. So if that's the red one on the bottom, the xylazine to fentanyl ratio is increasing. Still, though, the majority of our samples do have a lower xylazine to fentanyl ratio. That is not consolation with the trend that it's moving in that direction. So if you click the next slide. So we're going to dive in a little more deeply. And the next couple slides are kind of taking us from a bird's eye view, or maybe this is a bird dropping view. I'm not really sure. You can decide what you want to interpret this as. And then we'll go a little bit further into the samples themselves and then deeply into the story of a sample. So what's happening with xylazine? We're going to focus on that xylazine to fentanyl ratio. Over time, and you can see the distribution, those circles have really moved from, and fentanyl is 1. And so the xylazine ratio, as you move to the right, shows that we've had very high levels or ratios of xylazine to the fentanyl. It has moved, it has shifted down, and it is hovering much closer to a ratio as perhaps had been seen in the past in Puerto Rico and other places where a heroin to xylazine ratio or here a fentanyl to xylazine ratio is being replicated. There's a lot of a lack of clarity in terms of what is safe here, what causes wounds here, what causes withdrawal here, what causes a whole host of other things that we have yet to completely articulate, what complicates overdose, what does, and where is there potentially not a lot of harm, but sedation and the kind of feeling that people may be expecting from a drug that contains a heroin or a dope or however we want to name it these days. So I don't know if this is a good outlook or a bad outlook, but it looks like there's some taming of our emerging market, but to hover around a ratio. So the next slide. To look at the average of that over time. So it was a little wild and woolly there in 2021, as it was with many other substances in the drug supply. But this is the average ratio of xylazine to fentanyl. And so this isn't just the high end, this is all of the samples, right? So, and you can see as our samples have increased, the number of the ratio is also seemed to hover around more generally around 1 to 1. So if you click to, this is an animated slide, we'll now dive deeply, a little more deeply into, sorry, click one, there you go, the quantification. So you saw earlier from my colleagues that Philadelphia xylazine prominence in, so how much, what percentage of a sample is comprised of xylazine, and that hovers somewhere between 25 and 40%. It looks like it's 40% right now. In Massachusetts, in the New England region, that is about 7. So we are not hovering, we are moving towards perhaps or around, it's hard to say, but our xylazine median percent composition is 7. Our fentanyl is also substantially less than what we have in Philadelphia. It's hovering about 6. So if you will, it's about 1 to 1, fentanyl to xylazine. And that represented in the brackets is the 25 and 75th quartile. So you can see the range of the data. The next slide. So now we're going to just dive into a sample, a story of a sample. So this is the Rolls-Royce stamp, and this sample came in March of 2023. It had not yet been used, and the drug results on the bottom reflect the FTIR, the scan that was done at the site, and the active component above is the semi-quantitative ratio, so coming back from the lab, what we learned from the GCMS results. And what we saw there was, in real time, the technician identified this as having a major component of xylazine and a major component of fentanyl, and the xylazine being on top meant that there was quite a lot of xylazine on this, and knowing what they knew, because we had alerted and provided support, and they had a lot of experience using and messaging around harm reduction, they were able to counsel the person to say, this has a lot of xylazine, you have to be very careful because there are known wounds, overdose complications, and withdrawal at very high dose like this. So this was approximately 2 to 1 is this ratio. If you animate next and click again, a couple weeks later, the individual came in with the same these are sample level, not individual levels. So the sample came in and reported, and this is part of drug checking, is gathering use experiences. So the voice of people whose drugs connected to the sample. They identified that it had been used, that it was stronger than usual, and that they were starting to develop what they thought were abscesses. This ratio was about 2.5 to 1. And again, the technician saw major xylazine and major fentanyl and very little cut. So this was a conversation that was, again, with urgency to take care. The next slide, or just click again, is at week 5, the same stamp had been, it had reported with multiple overdoses, and we were alerted by the hospital system about this. And it was identified as this individual had injected it. They said that it was stronger than usual and tasted and smelled like chemicals. They indicated there was no dope rush, that they just went out immediately, but they were using a lot less than they used to. So 3 bags instead of 5 to 10. And they felt groggy and had a hard time walking on their second use. The next slide, if you animate this, was a cause for concern, and it was public health action that we could take just a few hours after getting this result in and verifying it with the site. So in this case, the ratio came through, and it was 4 to 1 of xylazine to fentanyl. The, again, major component of xylazine, a minor, and then still the opportunity to communicate at the time at point of care in those testing. And then we could label the sample itself as having some urgency around non-fatal overdose at this level. So this is an example of our stories that we can gather and glean from this important harm reduction data investment and the partnerships that we've been able to develop in forging ahead a community drug checking program. Next slide. So many of the effects we're going to be talking about throughout the day. I'm just going to touch upon these because I'd like to share data from reported use experiences from drug checking and other studies that we've been conducting in real time that had implications as well as implications for their actions. So beginning with the use experience and the utility of xylazine in the drug supply. The next slide. So the collection of experiences reflected sensations as well as numbing and burning and painful use at the immediate indication. Whether it was mostly by an injection, was the numbing and burning and painful use indicated at the site. More of the sensations throughout different sorts of different routes of administration, whether smoking, snorting, or injection. So in the next couple slides, you'll see those brackets indicate the route of administration. But the consistency and sensations of feeling it being a very strong experience, and that there was a rush, a high, maybe different from their fentanyl high, but one that was identified for some people as very good. The next slide. From our study in Rhode Island, which is a NIDA-funded cohort study, from February to August of this year, we have been collecting information from people who are using drugs in our drug checking program. This is a cohort study around drug checking. And in this case, most of the people that we're speaking with cannot detect that xylazine is there when they use it. Instead, it's after they have experienced a xylazine, what they think is a xylazine exposure, and that's derived from heavy sedation or because they've experienced abscesses or what they think are abscesses or wounds. And more excitingly, I think, and hopefully, is the preventive measure of drug checking, in that a number of people identified that they knew that there was xylazine because they had tested it, that they had actually worked with our program or another activity at that time to identify xylazine and see it in their drug supply. So this implies really a need for information for consumer safety. And that includes community drug checking, other test strips, and as you've been hearing about, really important drug seizure data to have public sharing rather than law enforcement only sensitive data sharing. The next slide. I'm going to focus on also use experiences from people who are submitting samples and telling us about their feeling more sedated and their level of consciousness, especially extreme and almost immediate tiredness and feeling like they were, the sensation was very sedating, and a concern around this. The next slide. And this, I thought, was really well captured by my colleague in Philadelphia, Megan Reed, whose work captured the voices of people who use drugs there on the streets of Philly, who shared this gentleman shook, and I'll read aloud his quote. He said, I don't like falling asleep and waking up and having no idea how I ended up on the floor, or why my arm is sore from, being in an awkward position, or why I have cuts and bruises and I don't know how I got them. And the next slide. This disruption of this use experience really is important because using alone and using in public both confer risk, which is both complicating the overdose experiences, as well as lack of movement, like you heard from Shook, and which could compound as circulation problems, compartment syndrome, and its worst case, amputation. We see this in people who are housed, as well as concerning around people who are using unhoused or are using in public. And especially from Shook, you heard concerns about victimization or other harmful activities that may come to an individual who is using in public and may have suffer consequences of heavy xylazine exposure. Environmental exposures were not captured in any of the voices that we heard, but throughout the year, because we have seasonal variation, heat and cold exposure is really a concern. These data imply a real need to increase the witnessing of use and a response to oversedation that includes heavy monitoring. And that may be a host of collective responses that we're exploring and some embracing in Massachusetts. That includes overdose prevention sites. We have launched the Massachusetts Overdose Prevention Hotline, which is very similar to Never Use Alone. And then we have a SPOT, which is a supervised place for observation and treatment for people to be cared for and monitored after use. But then very simply and really able to be implemented without policy, but is really encouraging safe and trusted partnering use and monitoring. The next slide. It also reminds us that we have a wonderful collection of naloxone products, OTC to prescribed, standing order to prescriptive authority, and really we do have to come back to the other basics of breathing and rescue breathing, which was a hallmark of early work in overdose and prevention efforts. And while having a product like naloxone available is critical, so too is an emphasis on breathing and supportive breathing for individuals who potentially appear to be overdosing when xylazine is around. The next slide. The use experiences with respect to wounds have been profound, and that really has been across the routes of administration. Last week, we had a participant appear with wounds on their ankle, and they were only snorting their drug. And having abscesses or concerns at their injection site is not an uncommon experience for people who inject drugs, but the number and the pain, as well as how quickly they move, is very important to respond to this. So the next slide. Those considerations really around wound prevention, it's really hard to understand. We need heavy epidemiology. I'm very excited to be part of an EPIAID in my state to be looking at this, but it is far from sufficient to be able to understand risk factors, how they're exacerbated and how they progress. But what we do have a better understanding, thanks to the harm reduction community and the wonderful networking that has been coming from street-based care, is a clear practice and the need for information exchange that is emerging. Scaling up that care is going to be a phenomenally important public health activity. It is very unclear for how treatment programs are supposed to respond, how EDs and hospitals, they are emerging to respond, but community health centers and especially the criminal justice system is starting to see wounds as well that need to be attended to. So this implies a real need for systems change from my perspective and from these data, for first a task shift to peer-based, mobile, and non-institutionalized care, especially from harm reduction groups, and the ability to compensate them to be able to do this. And then a makeshift to empower people to self-manage. And this form of makeshift medicine is actually very similar to what we do for naloxone, where we have task shift and we have been makeshift medicine responses to this important health problem, this collection of health problems. So the next slide. To remind us, I wanted to put in a quote from someone in Massachusetts who shared the consequences of some of the self-management and sort of the importance of first trying yourself to take care of oneself, but not having the right supplies. So he shared, I figured I'll drain it myself with my needles, and I put it in and I drained it myself a little bit, and then the blood would start trickling out with like a little bit of pus and shit, and it would smell. And I was like, oh, all right, that's clean, Next time I drain out, maybe I'll be better. Before long, all the spots I'd stabbed to drain, it turned into a big purple nipple. We have to do better as healthcare providers and public health professionals. We have to do better. The next slide. The last set of reported use experiences that we've gleaned from community drug checking data and reports have been importantly hearing from people, especially who are injecting, about rashes and paranoia, anxiety and panic attacks, which may reflect more of the xylazine constellation of withdrawal, but also compounded because of the 1-to-1 ratio, likely heavy fentanyl and opioid withdrawal, which is that they woke up feeling sick, that they were very uncomfortable, and they didn't take that using this didn't take their dope sick away, and that their withdrawal came back faster. The next slide. What does this imply? It's the experience of self-managing is going to be an expected consequence, right? Trying to self-treat withdrawal is an expected experience. So seeking benzodiazepines and stimulants have been what people have shared with us helps take care of their xylazine withdrawal, or what they think is xylazine withdrawal. They may re-administer xylazine and fentanyl to self-care and self-manage, but we need accessible alternatives because they are few. And we need current withdrawal care, the options that are scalable. And so safer withdrawal care alternatives and easier to start medication treatment have to be part of the response. That includes, and we've pioneered this in Rhode Island, single-dose buprenorphine from pharmacies to treat withdrawal. Many places have ED-based opioid withdrawal supports that could do more and better. And rapid methadone starts thanks to our direction during COVID for hospitals and EDs and mobile teams. And finally, some interesting data on quick start buprenorphine involving self-administration of naloxone and immediate start of buprenorphine. These are possible, and perhaps the research will show us other xylazine withdrawal supports in the future, but these are important considerations for addressing the withdrawal. The next slide and last slide. Until we have research to answer our many questions, the strategies really need to minimize dose and exposure to xylazine to mitigate harm and to invest in innovation, innovative interventions, task shifts, and makeshifts. And I've talked about a number of these, but they're important. Information through drug checking, reducing barriers to medication treatment, and providing heavy withdrawal supports and broad-scale strategies are critical. Mitigating harm through all of our efforts for overdose prevention and better monitoring, as well as new innovations like investing in mobile teams and wound care for their lower barrier, and improving the ability for people to self-manage wounds themselves. So last slide, I have to say it, we really need to invest in our data. Sorry, click one more time. Investing in the data. And that really is all of what I shared with you would not be possible without community drug checking data. None of those voices of people who use drugs, none of the information from the drug supply. And that is a critical mirror that we're able to hold up to local supply and local shifts in the supply. So I please thank you. It cannot be, learning about the drug supply can't be a critical component and not exist without, and exist with great indecision on clarity on legality support and direction for community drug checking nationally as well. So thank you very much, and I'll stop that.
Dr. Green, thank you so much. And we're making our way through. One of the ways I think about this from the CDC, a lot of the information about the xylazine exposure information from human samples, then to the law enforcement thinking more about the supply, and Dr. Green more about the drug checking and the experience from individuals who use drugs. So thanks for that kind of third way of looking at things. We have one more speaker this morning. So Dr. Green, if you want to join the table here, and then we'll go straight into Q&A after our next speaker. And on her way up to the stage is Erin Russell, whose current seat is as principal at Health Management Associates, but a prior seat included a leadership role within the state of Maryland. And so Erin, we'd love to hear from you about what you learned in Maryland and what we can think about as we continue to explore these data questions and research priorities. So the microphone's yours.
Thank you. Thank you so much for having me. I'm Erin Russell. As was mentioned, I'm a principal with Health Management Associates. Health Management Associates is the largest healthcare-only consulting firm in the US. Prior to that, I spent the last decade with the Maryland Department of Health, building Maryland's harm reduction portfolio. And I got to work on all aspects of the overdose crisis in that state. So I'll be drawing heavily on that experience for this presentation. Through my presentation, I'll describe a bit about how we established a statewide drug checking program, and then present some results from that program. And I'll focus mostly on policy implications that would be extremely beneficial for us to translate what we learned in Maryland to other states. You'll hear a lot more detail about the on-the-ground experience from speakers later in this afternoon, including people from Maryland. So I'll keep it rather high level. All right, so we created the Rapid Analysis of Drugs program to get a sense of how xylazine was showing up across the entire state of Maryland. And that's what was unique about this program, is we were able to establish it in all corners of the state. And we partnered with the National Institutes of Standards and Technology to conduct the tests in a lab setting so that we could use a DART mass spectrometer and get really comprehensive results for our programs. This RAD was built upon the existing harm reduction infrastructure that we had in Maryland. There are 24 jurisdictions in the state. We have syringe service programs in 14 of those. And the Department of Health approves and monitors and supports all the syringe service programs. So we were able to reach out and partner with them in order to establish this program. And the legal coverage is in Maryland state statute. That legal coverage specifically is for the handling of otherwise illegal paraphernalia that allowed for us to even do these tests. So a quick note about syringe service programs. They offer sterile administration equipment to people who use drugs. They're grounded in harm reduction, and so they offer low barrier services. It's a person-centered approach that meets people where they are without expectation that they change anything about their drug use. And they are comprehensive hubs of care these days, offering a variety of services from testing, women's health, hepatitis treatment, and telehealth often. And so drug checking was integrated into this kind of system of care. And I emphasize that because we really added to that system of care by bringing drug checking into that context. And also, our programs in Maryland look a lot of different ways, and Tracy touched upon this. Some are operating out of a mobile van. They can be on street corners, people with backpacks walking around the street and offering supplies and education and resources to people they encounter, or a fixed site like brick and mortar site. And so drug checking took place in all of those different locations. And we demonstrated the effectiveness of doing this field-based sampling. And so this is another thing that was unique about our program. As I mentioned, the tests were done in a lab setting. That's actually Dr. Cisco, who was our partner at the National Institute of Standards and Technology, and helped us set all of this up. And so programs, we trained all of the staff and at syringe service programs. 8 programs participated in the pilot, and now it's expanded to many more programs across the state. The lab and the Department of Health provided training and support to program staff so that they could take swabs in the field of paraphernalia. And those swabs, I'll show you a picture in a minute, look like they're about 2 inches long slips of paper. And so, like I mentioned, just want to emphasize that staff and volunteers were doing these swabs in the field, sometimes in homeless encampments, on people's doorsteps, wherever they were offering services to people who use drugs. Those swabs were taken of mostly baggies. That was the most commonly, during our the pilot period, the most commonly sampled paraphernalia item. But this shows you a variety of paraphernalia that could be swabbed. The swabs were then placed in a small envelope. They were given a unique ID, labeled also with the date of collection and the program name. That's the only information that went to the lab. Those small red envelopes were placed in a larger envelope, and they were mailed using USPS to NIST, which their lab is based in Maryland. Programs also collected optional data. This was done again by program staff, asking the person who provided the sample, what drug did you think you were buying, and how did this make you feel, and any other location information that they were willing to share. Again, those questions were completely optional, and about half of program participants also offered information in response to those questions. Once the lab received the sample, within a couple days, they would conduct the test and put the results into a shared Google Drive spreadsheet. So that made it possible for programs and the Department of Health to see the results as quickly as possible. And programs would then be able to align the ID that they put on the envelope with the result they saw in the spreadsheet, so that they could communicate those results back to the person who provided the sample. The number one priority of this program was to provide more information to people who are using drugs in Maryland, and to support program staff with communicating that and providing any supportive education or additional information that would help reduce overdose and overdose risk. So we wanted to make sure that those results didn't have to filter through the department and then get sent out. They went directly back to the program. Many programs would print out the results and post them up on the walls if it's a fixed site location or a mobile van. They would share back aggregate information to all of their program participants. But then again, those individualized results could go back to the person who provided the sample. And just so this is very different. It's different than a lot of drug checking you will see in other locations where the drug checking is done on site, and so the person can get their results within 10 to 20 minutes. This is more, we call it more surveillance. It's more big picture. People are getting their results after they've ingested the drug. And so it's meant to complement on-site drug checking and give us kind of a confirmatory test type of approach. All right, so just one outcome I wanted to emphasize was this paper published that demonstrated again the effectiveness of these field-based samples. So it is feasible for people who are not trained lab technicians to be sampling paraphernalia out in the field and to get high quality results from that. From day one, we saw xylazine in our samples. It was in the majority of samples, and it was one of the reasons that we were even able to advocate for this program to start, because our syringe service programs were sounding the alarm about xylazine. They had seen it years before we were able to get this comprehensive drug checking program off the ground. And so we were not surprised. What we were surprised by was the dramatic amount of xylazine and the fact that it was statewide. We had only a couple counties that had issued alerts prior to us doing this systematic sample collection. And to see xylazine across the state in multiple counties was really astounding and really mobilized the Department of Health. We also highlighted concordance, which is the alignment between what someone expected to buy and what ended up being the results in the sample. And this is emphasized in the Morbidity and Mortality Weekly Report that was published on this program. And what stood out to us was that in the majority of samples, it matched what they expected to buy, but there was more active ingredients in the sample, in the drugs, than was expected. So people generally were surprised by what was found. And in any situation in which someone expected to buy heroin, there was no heroin in the sample, and no one intended at the time of this pilot, which was through 2022, no one was intending to buy xylazine at that time, at least was reporting that at that time. So this what this shows is that people need information. There's a real gap about what people expect to buy, what they end up receiving, and it just shows how volatile the drug market is for everyone. So just a note, as moving into 2023, the proportion of xylazine positive samples has decreased. The Department of Health did expand this drug checking opportunity to more programs. The pilot project started with 8 programs. It's now expanded to many more. And so there's more samples coming in, which has affected the ratio. So just it's a data issue there. But we are continuing to see it, and you'll hear more about that later this afternoon as well. All right, so I'll spend a little bit of time talking about the impact of this project and how I see it affecting us nationally. So first, there was a lot of public awareness. This got a lot of press, and that had a very positive impact on our programs and was helpful. The results of the drug checking program were helpful to alert broadly the general public that xylazine was in Maryland and that we needed to pay attention to it. The Department of Health also directed funding to wound care prevention and treatment. This was a common theme throughout the pilot and continuing into present time, that syringe service programs were seeing wounds, and the information obtained through the drug checking program allowed them to be more confident in the way they were treating wounds. And so the Department of Health funded wound care prevention in terms of providing wound care kits that could be handed to people, offering treatment on site, staffing, like hiring and staffing nurses on site at programs who could treat wounds in real time, and then also providing general education to staff at syringe service programs about triaging for wounds. If someone shows you a wound when they come in for services, how do you respond? When do you tell someone to go to the hospital, or they need immediate care, or so just overall, it increased our syringe service program's capacity to talk about and address wounds, and that has been an incredibly positive thing. Having these results from the drug checking program increased engagement with participants. Like I mentioned, people were very interested in what the results were, even if they had already used the drug. When they were surprised about it, they expressed interest in other services. And people reported sharing the results with others. So it not only benefited people who were accessing syringe service programs, but also their broader social networks and communities. I have a couple more slides and I'll wrap it up. All right, so it is my recommendation that technologies are offered on site at every harm reduction program, and that xylazine and novel psychoactive substances are discussed more in an overdose prevention context by coalitions, that this is something tracked by medical examiners and coroners, and that funding continues to be prioritized for harm reduction programs. Harm reduction programs are the reason we were able to do any of this drug checking. As I mentioned, it was only in the context of Maryland Syringe Service Program state statute, which still is not that encouraging to all people to participate in syringe service programs. So legalizing drug paraphernalia would actually facilitate drug checking in an entirely new way. So even if we create a lot of new technologies, it's not going to be accessible to everyone. And those technologies need to be implemented in the context of a supportive harm reduction environment. So just knowing what's in the drug supply is helpful, and it's great to increase surveillance and understanding, but how are we using that information? It's really, people need to be linked to non-judgmental care that's offered in a low barrier manner. And if that doesn't exist, then we're just giving them, we just have more data, that's it. And finally, if we have more data and we're looking at the supply, we're gonna see that it's volatile and it's deadly. And the only answer to that really is safe supply, and offering people prescribed drugs that can manage dependence. And this has been done prior to the introduction of methadone. It's done in other countries. And so, we're going to continue to see a really intense drug supply. And so this is a policy recommendation that will help us to, again, give answers to people, not just information. All right, so in closing, a state, national, regional drug checking program is feasible. We can get high quality information on the drug supply, but that's only going to be useful if it's applied in a robust harm reduction network. And we need policy reform in order to actually make this happen in a meaningful way. And that's it. Thank you very much.
Erin, thanks so much. You brought us yet another way of thinking about it and gathering data from drug checking in a way I hadn't thought about in the swabs. So thank you for that, which rounds us then. It's time for our Q&A. So if we could pull Dr. Ko back up on the screen to join our panel virtually. So she'll be just, right in the middle visually of the panel here. And we have a host of questions. Including, do we have Dr. Ko back on visually so that we could see her? There we go. Hi, Dr. Ko. You get that first question right back to you. What can you tell us about the presence of data from Puerto Rico in suitors?
Right. So Puerto Rico was originally funded for suitors during that timeframe that I had presented data, so 2019 to 2023. However, shortly after starting or kicking off that our overdose data to action program, Puerto Rico ran into significant challenges, including COVID-19, which we all experienced in 2020, but they also experienced Hurricane Maria as well as earthquakes, making surveillance difficult in their jurisdiction. So we worked with them to change their work plan, and I guess that's the history of why we don't have them included in that report. We are interested in helping them increase their surveillance related to overdose deaths, and they are funded in our next overdose data to action program, which is has launched in several jurisdictions already.
Fabulous. So should be back in in future data. Great. So let me ask a question to all of you. So I'm looking at Dr. Ko there and now looking at the panel. I have like 7 questions here, so we're going to get through what we can. But one that's come up in a couple of different ways, just want to level set in all and this will be a rapid fire from each of you. Did any of you see xylazine only? Either in kind of what it was the individuals were seeking or in the testing. Amanda and Van, anything xylazine only?
No, for the most part. However, I don't know if you want to touch on this as of late, kind of what we've been learning.
Right, we do have individuals seeking xylazine only. And I think I first heard of this about 2 years ago. Drug commanders in their units, especially up in the Poconos, were saying individuals were coming down to Philadelphia just for xylazine. They interviewed one subject that she said she's been getting high since 14 and substance abuse, and that was the best high she ever experienced.
Okay.
So unfortunately.
So some seeking at least of xylazine only. Dr. Ko, I saw an expression change which could have meant you wanted to jump in. So I'll turn to you.
Yeah, sure. In our report, the MMWR, we found that 99.5% of deaths with xylazine detected involved IMF, so illicitly manufactured fentanyl. Only 4 deaths had xylazine listed as involved that did not have IMF involvement. So very few.
So so maybe seeking xylazine only, but it's very few then in the resulting deaths. Okay, Tracy and Erin, anything to add on there?
We have not.
Okay, Erin.
Yeah, perhaps my colleagues from Maryland later this afternoon can speak to what they're seeing currently in the state, but at the time of the publication of the MMWR, we did not.
Okay. And so then actually picking up on what Dr. Ko mentioned, and this is, I think, to any of you who want to jump in, but it relates to the overdose with xylazine, and given, I think this was data that you shared, Dr. Koh, that people were more likely to have a pulse in overdose with xylazine than when xylazine was not present. What does that suggest about the doses of reversal agents and the role of oxygen?
So
Do you want to jump on that one?
yeah, I'll jump in here. So yes, we found that 53.3% of folks with xylazine detected had no pulse, compared to 62.2% without xylazine detected. So remember that these are among IMF involved deaths. And so I think this indicates that naloxone should be administered even when xylazine is suspected. And of course, I think there is some hypothesis related to if xylazine is detected and is present, perhaps that means that there's less fentanyl, and that's why we're seeing this result. So, I think that's something to consider and be warranted.
Yeah. So considering the kind of comparative presence and the impact. All right. This is a very specific clarifying question for our HIDA team. And the question is whether it was in the fentanyl samples, did you see medetomidine or dexmedetomidine?
Not yet in our samples that I was discussing, but like I said, DEA put out a report last week, so I would imagine that soon, if not already, it'll start to show up in the numbers.
All right. And do you think it's, and this is where actually all of my pharmacy professors right now are saying, Susan, decide how you're going to pronounce this. So medetomidine or dexmedetomidine. Was there a distinction there, or this was the DEA piece? And were they speaking just of medetomidine?
Yeah, so we've been kind of discussing the alternatives that are going to start appearing ever since the scheduling began. And so medetomidine and dexmedetomidine just happened to be the two that, were, I'll say, next in line to kind of cycle through. And that DEA report was specifically for those two substances.
Okay, super helpful. All right, this is a question about, well, there were a couple of questions who said, what's going on in Philadelphia?
We're wondering the same thing.
So any thoughts there as because I think it might be Philadelphia today or recently, but it was certainly Puerto Rico, and we'll hear more about the Puerto Rico experience this afternoon. Thoughts there, Tracy, Aaron, this might get to kind of the what you're seeing in the experience there, but any thoughts there? Not necessarily what's going on in Philadelphia, but why do we see, any thoughts on why we see the peak and the additional penetration? And Van and Amanda, you're always welcome to jump in.
I think Van can touch on this.
Right. What we surmise is about 10 years ago, insurance programs were sending individuals from Puerto Rico to Philadelphia for treatment. So then the drug supply and the dealers followed that trend to Philadelphia to, as you say, serve up their customers in Philadelphia that were leaving Puerto Rico to seek treatment in Philadelphia. You've seen that in the past in Pennsylvania. We know of intelligence of drug dealers going to the rehab centers outside. There's a huge one in Williamsport where they go set up shop waiting for them to come out of rehab to hopefully that they relapse and they have a big consumer base.
Yeah, so potentially some opportunistic behavior. And I think it's something we continue to explore and learn. Tracy, Aaron, any thoughts there?
Having not lived, worked, or conducted harm reduction research in Philadelphia, I should probably not be commenting, but I would just say, but being married to a history teacher, I think I can say, which is there's a history from many different perspectives. So it's really important to hear from many people, and we hear throughout the day, but also to look to our archives. And we have quite a lot of data from law enforcement and other sources back into those days from New Jersey as well as from Philadelphia area. And I think maybe we need to do more homework to understand why and how, but also really focus on what we have, what's happening right now,
Right.
To be responsive. And
Tracy, that's a great point in reminding us that what we're about today is thinking about what are those research priorities and what is it that we want to explore. All right, now this is a question that may go beyond what it is that you've seen in your data, which that is an okay answer. But was there a change in the experience or presentation of individuals overdosing or change in the severity presentation of skin wounds when the supply transitioned from bottles to bulk powder?
I think that might be a little early to determine. Anecdotally, I haven't heard of a difference. I know that, you know, we're still even kind of studying how the ratio of the xylazine to fentanyl is kind of affecting that. So I'm not even sure if, I know that we personally have not dabbled in the difference between the liquid and the powder and what that's doing for the skin lesions, but.
yeah, I think we don't have a sense of the presentation in our emerging areas of, but you can make powder from the liquid too. So
Right.
there may be, you know, we were seeing a lot of overlap still, I think.
Right. Right. All right. We were able to get through some of our questions. I'll note that I'll ask the in-person folks, if you would write your questions down, it lets me put you in the queue with those that are coming in online. But let's join and thank our session one speakers for helping us with just getting a better sense of the different data sources and the way to understand the presence of xylazine, and then starting to help us with those research priorities. So thank you each for joining us and sharing your insights.
Thank you.
Thank you.
And as you do in hybrid meetings, it's time to roll on into session two. So take a deep breath. As our panelists here leave the stage from session one, we are going to move right on into session two, where I'm going to have to improve and remind myself of my pharmacological training. And we are going to talk about pharmacological and clinical research needs. We have 4 speakers for this session, and they are going to talk us through studying xylazine drug properties, the impact of xylazine opioid combinations, and research priorities for closing the gaps in clinical knowledge about xylazine. In this session, we are going to take a few questions after each speaker. So those of you who are in the audience and have questions, you're going to have to write quick and get those up to me, and online, just keep those coming in. Just know that we're going to hear from each speaker and then take questions right after they finish. So with that, our first speaker is ready to take the stage, and we are thrilled to hear from Dr. Keith Burkhart. Come on up while I finish the intro. Dr. Burkhart serves as the Senior Advisor for Medical Toxicology in the Office of Clinical Pharmacology, the Division of Applied Regulatory Science in FDA's Center for Drug Evaluation and Research. And Dr. Burkhart is competing for longest title today. I will let you know who wins that, but we are thrilled and looking forward to your presentation. Take it away.
Thank you so much, Susan. And I appreciate the honor of talking to you today about the pharmacology research needs for xylazine. And I want to start by acknowledging some of the division team members who worked on some consults related to xylazine for FDA. That's Rebecca Raz, Lydia Stavitskaya, and Donna Volpe. And you're going to hear some of the research they did as part of this presentation. I'm going to start by discussing a little bit about the pharmacology that we know of xylazine, but the focus is going to be on discussing some potential secondary pharmacology, what we often call off-target effects that warrant further investigation as well. You've heard already about xylazine as the veterinary product, being an alpha-2 adrenergic agonist. Has similar properties and probably a lot of similar actions as clonidine, tizanidine, and I'm going to say dexmedetomidine. It reduces the release of norepinephrine and dopamine in the central nervous system, And you've heard of this from Dr. Ko as far as what these actions do. And the talk today is going to focus a little bit on the sedation aspect of it, what happens with blood pressure and ventilation. We do know some about the metabolism of xylazine. It undergoes extensive phase 1 and phase 2 metabolism, as was documented in an overdose victim by Meyer et al. And these metabolites seem to resemble what's been reported in some rat studies as well. As far as its sedation, it is reversed by alpha-2 adrenergic antagonists. But I wanted to spend a little time talking about naloxone here as well. There's always been this question, what would happen if you give high doses of naloxone from some of the research that's out there. The sedative effects of xylazine in chicks were reduced in that by pre-treatment with high naloxone dosing. And it's been suggested that naloxone may cause some endogenous release of endogenous opioids. There's a recent pediatric case series that was published of pediatric clonidine overdoses. And 50% of these responded to high doses of naloxone with a positive clinical response, including improvement in their mental status. And some breaking news here, the speaker is going to follow me today, Dr. McElligott, and her lab is going to talk about xylazine that's been studied in, with naloxone administration as well. I give a shout out to our colleagues in the controlled substance staff who got this German dissertation translated into English for us to review. And from back in the 1960s, collaboration from Dr. Rubisch for her medical doctor dissertation with the University of Dusseldorf, and the drug supplied by Bayer. She studied the anxiolytic and sedative and analgesic properties of xylazine. In this series, oral xylazine up to 40 milligrams produced our classic sedation and sleep before some of these patients were undergoing procedures. And none of these patients seem to have significant effects on their blood pressure at these doses, and they all seem to recover in about 5 hours. But intravenously or intramuscularly, xylazine in the doses here produced that sedation with significant drops in blood pressure in not all patients, but a number of patients in this series. None of the patients reported euphoria from this administration. But of note, especially the focus on ventilation here, some of these patients had periods of apnea that lasted up to about 25 seconds or so with that shallow breathing. But this seemed to be then followed by recovery, and that by normal breathing, that seemed to maintain a normal minute ventilation at 7 minutes. This is xylazine alone. Limited data is available about the secondary or off-target activity for xylazine. So understanding or learning a little bit more about these targets could influence our clinical management and reversal strategies. The FDA has developed a tool, what you call PHASE, Public Health Assessment via Structural Evaluation. And this uses in silico tools that allow for the rapid assessment of misuse liabilities with emerging drug threats. We have a couple of publications on this in which we've looked at characterizing the fentanyl analogs and also kratom alkaloids. And the figure there shows some of these tools that are used in this assessment. We have structural similarity analyses that are done and target predictions that are done. And when molecular docking is available, we'll use that in the modeling and analysis as well. Here's for the paper on kratom. The software we use analyzes for over 2,000 receptors, and what we found beyond the opioid receptors for some of the kratom analogs it was that there was predictions for adrenergic receptors binding for alpha-2 and as well as serotonin receptors in that also. So this limits from a vast number of, can help focus what research you might want to do on off-target receptor activity. And we actually collaborated with the Brian Roth lab on the psychoactive drug screening program and confirmed the binding of at these receptors. Now, how about for xylazine? We applied this for xylazine as far as starting with a structural similarity assessment. And no surprise, I think, as far as xylazine being found to be structurally most similar to clonidine, to xanidine, and also of note, levamisole. And the similar moieties are highlighted here for you in red. Now, how about those secondary pharmacology off-target potential activity? And for this slide, it captures that, but I did want to highlight a couple of things. And for imidazoline 1 is a very strong interest. And this may be actually part of the class activity, as this is known for clonazine, tizanidine, and dexmedetomidine in that as well. Of note also is the nitric oxide synthase potential activity there, and I'll talk about this in a moment. Of also stronger predictions is the trace amine associated receptor 1. For time, I just put some backup slides for you to take a look at for there. And then there's some low confidence predictions, some cholinergic receptors and the serotonin receptors, which I still think warrant some evaluation as well. And part of our expert assessment is we look at labeling to see if there's any evidence for this target activity and search the literature. And I just want to point out from our veterinary label that there may be some evidence from some of the adverse effects we see that there could be some nicotinic receptor involvement as well as some serotonin activity, at least from this. Going back to that dissertation, the Rubish did study and evaluate the hypercapnic ventilatory responses for xylazine, reporting on three or four patients seemed to maintain the hypercapnic response. And this is important when we're talking about opioids or combination with opioids as well, because of the CNS depression that you have with this, and hypercapnia is a very common part of that overdose. I want to point out here that there's, at least in a rat model of dexmedetomidine, studying these different receptor activities, it was noted that the imidazoline 1 activation seemed to help with maintaining the respiratory drive. What about the serotonin receptor activity here? And the FDA has been investigating this, and we recently published on our experience looking at paroxetine and quetiapine here this past year. Paroxetine being a selective serotonin reuptake inhibitor, it reduced the hypercapnic ventilation on its own and then had additive effects when combined with oxycodone. And there's literature support for serotonin role here. I was a little surprised by the results in quetiapine. Very sedating drug. I've taken care of many overdoses for this, and we have to intubate in that. But at least in these therapeutic doses, even with its anticholinergic sedating properties, it did not depress hypercapnic ventilation. So really, there's a lot of need to understand what goes on with xylazine alone, xylazine in combination with opioids, and other products. We're seeing such polypharmacy overdoses here, and what happens when you give naloxone. So clearly calling for a lot of ventilation studies, and that was xylazine in all this picture. Now the wounds, I just wanted to show one of those that has the beginning of some of these wounds through there. And as we've heard from other speakers, I don't know that we understand the full pathophysiology here yet. But this hit that we have for nitric oxide synthase, what the role may be there, also warrants some further investigation. In some preliminary studies, we know nitric oxide is important to wound healing, including the process of angiogenesis. In a rat splenocyte model, xylazine shows dose-dependent immunomodulation. In lower doses, it seemed to be stimulatory to the immune system, but then in higher doses, it seemed to inhibit some of these factors. And there is evidence that they couldn't put all this together for nitric oxide signaling. But there was difference when they studied clonidine as well. It didn't seem to have the same effects that xylazine seemed to do in this study by Kupik et al. I have to go back to the structural similarity to lamazole. It's been associated with autoimmune reactions, vasculitis, agranulocytosis, and Bishnoi and dermatology colleagues recently published calling for research into potential immune-mediated vasculopathy by xylazine. And some more breaking news. We've seen a preprint about the kappa opioid receptor, which is also known to cause immune modulation also. So in summary of what these pharmacology research needs, I do want to note that the FDA is doing research in this space and funding research in this space. As far as for the pharmacokinetics aspect to this, we have a contract with the American College of Medical Toxicology now for what I like to call near real-time toxicosurveillance for patients that are presenting from the field after being resuscitated. And we're going to be getting quantitative analyses of xylazine and the drugs that are when these patients present at the hospital through there. And I'm putting a plug in for a speaker who's in the same panel today. Dr. Kotulski is doing some of the lab working as a subcontractor with ACMT to give us some of this data for analysis. And we're starting to get some results back from that work, and that as we speak. Pharmacodynamics, I've just learned in reviewing the slides for the speaker who's following me that the Brian Roth lab has already done some secondary pharmacology activity that you're going to studies on xylazine that you're going to hear about here in a moment. And you've already heard me stress the impact on respiration and need for drug-drug interaction studies. And the wound infections, another speaker on the panel, Dr. Gamboa da Costa, is going to go into some detail of the research that's being planned there. And as I stressed, we need to know what antidotes are useful for these settings. And with that, I hit right at 10 minutes for you there, Dr.
You know, Dr. Burkhardt, I was also going to give you that award for timing. So that was great. I will note as we go to Q&A, I did get one written Q&A. It's more policy and outside the role that Dr. Burkhardt has. So I'm going to hold that for the end of the day. So any questions here in the room to follow up? I've had to step away from the computer, so I'll say to the online, would need you to shout it out. So any questions here in the room for Dr. Burkhardt? Yeah, you have to wait just a second or the people online will not be able to hear you. So I will hold the mic.
I don't know if you know the answer to this, but are there any upcoming studies scheduled? I'm from Philadelphia, Kensington, for the brain and the effects of xylazine so that we can have actual studies for it and facts?
Not that I know of at this point. The study we're funding on the toxicosurveillance, Philadelphia, that's 17 centers around the country. One of the sites is from Philadelphia. So we'll be getting, what we're going to do in that study is look at all these results and correlate that to what we've seen with the patient and that as well. So in that way, we'll get some results. But outside of that, I'm not sure of any other research right now.
But I know we'll hear from some additional speakers. That's part of the, as you noted, Dr. Burkhardt, we've got 3 more speakers who are sharing research, and that's part of what we want to stimulate today. So anything else here? Oh, yeah, sorry. Well, in the room, I'll say, raise it up high, or I'm not going to see you.
Hi, I'm Rachel Holbert from Prevention Point, Philadelphia. And I was able to ask our healthcare providers and our participants and other researchers, what they wanted to learn today. And their questions really do relate around the mechanism of action around the wounds and why they're not affiliated with injection sites necessarily. Just, and also the relationship between the bacterial contamination in the wounds, like they're not always infected. And it's very interesting, like, is there particular bacterial or bacteria, that affect some of these wounds more than others so that we have a better idea of how to treat on the ground? And then the last thing, it's a little bit more long reaching, is how, this goes back to that other question, not necessarily with the brain, but other like internal organs. Does this have anything to do with, long lasting effects inside?
So I think that's a great tee up of all the things that we want to pursue. Do you think any of that, Dr. Burkhardt, as you're thinking about what you're doing or what you're learning, any thoughts you want to share?
Well, as I mentioned with the effects that it does on the immune system that we don't fully understand or have characterized yet, I think that's a critical thing for some additional research here. It clearly has shown some evidence of immune modulation, what that has to do with starting the wounds and or as they progress, and what that means for the bacterial infections that are there. Can't imagine there's not something that it's doing something that's impacting all that. And Dr. Gamboa da Costa is going to talk about some planned research in that space, and that coming up now.
Perfect. That took us to the end of our time here, but if I saw there was a question in the room. If you go ahead and write that down, we'll see if what we can do to bring that up. Let's thank Dr. Burkhardt for joining us and sharing his research. And we're going to turn next to Dr. Zoe McElligott. I knew I would get it right on the second one. And Dr. Burkhart, you did such a great job of previewing all of the other speakers that it's made my job so much easier. But Dr. McElligott, we are looking forward to the information that you are bringing us from the University of North Carolina. I'm going to step out of the way because I know there's everyone wants to hear what you and all of our other speakers have to say. Pick it up.
Thank you. Thank you so much. And I really want to thank the Reagan-Udall Foundation for having me here today. This is a real honor to be amongst all of you amazing colleagues. So I want to sort of tell you the story of how this research started in my lab a little bit. It is a very organic and beautiful process. And I really feel like the data that we've collected thus far and that we continue to collect really show what happened when a concerned group of people get together and really put a lot of effort towards some of these projects. So without further ado, I really want to highlight Madigan Bedard, who is a senior graduate student in my lab. This has been her passion for the past 10 months and really started when she dipped her head into my office on January 4th of 2023 and said, "Hey, have you heard about this xylazine stuff?" And I said, "What are you talking about? The anesthetic?" And we in my lab have never used xylazine as an anesthetic for our preclinical research. We use isoflurane for surgeries. And the reason for that is that I've always studied the adrenergic system, and I was very concerned with how opioids could influence the adrenergic system, and particularly alpha-2 receptors. So my postdoctoral work was really focused on this. And so I was very intrigued when Madigan said this, and she said, "This is really interesting and it's really upsetting, and there's a lot of bad stuff going on." And I said, "We need to figure out what's happening." So we launched this spring into doing this. So we first dove into the literature to see what we could find really on xylazine by itself. So in the preclinical literature and the rodent models especially, xylazine has mainly been looked at alongside with ketamine because it's used as an anesthetic that way for preclinical research. However, there was a little bit of data out there looking at xylazine and how xylazine could affect opioids. And in particular, there was a paper that looked at condition-placed preference, which is a way that we measure animals' ability to learn about a reward-associated association. And what we found, or what we found in the literature, was that people were using these really high doses of xylazine. And this is a problematic thing because you depend on the animals to be able to move, to learn, and to tell you what they're actually experiencing in terms of the reward. So the lowest dose that these folks were using in this 2008 paper was 2.5 mg per kg, which we knew would be sedative in those animals. And then furthermore, we found some other very interesting data that was suggesting that there was additionally, again, this sort of crosstalk between what we thought of as the alpha-2 adrenergic system at the time and opioids, where animals had been made tolerant on xylazine, and this tolerance required additional opioids to shift them to an analgesic plane. So what we decided to do at the time was that we really wanted to start at square one. We needed to look and see how xylazine was affecting locomotor ability so that we could plan and do other sorts of assays within the lab. So I'm going really slow already. So to do this, basically, we just do some really basic open field locomotion. We give the animals different doses of xylazine, and we ask them what they do for about 60 minutes later. And we look at this locomotion and we characterize it a bunch of different ways. So I'm only showing you a little bit of data here, but instantly we were seeing some really interesting things. So we looked both in male and female animals. Traditionally, preclinical researchers for years and years and years focus mainly on male animals because female rodents cycle every 4 days and we're considered too hormonal. I can talk at length about that. But what we found is that when we use what we were considering low dose xylazine, very, very low dose of 0.5 mg per kg, was that the female animals were actually somewhat stimulated by this dose, where the male animals were showing no difference from saline. So we figured that this was a really good dose for us to look at to see if it could boost what was going on with fentanyl, because we weren't going to see any of this sedation type thing happening. And if anything, we're getting a little bit of a stimulus bump. So we were like, well, okay, that's interesting. So we moved on to what we do next and what we do best. And I'm going to kind of pass over this slide really quick because we wanted to understand what xylazine was going to do to opioid withdrawal syndrome. That's something that we study very intently in my lab. So I'm just going to kind of click through all of this because I don't have time. What we do is a very rapid, quick, and dirty sort of acute precipitated withdrawal. So we give the animal an injection, and then 2 hours later, we give them a second injection. The first injection will be an agonist. So usually it's an opioid in our hands. The second injection is an antagonist. Usually we're using naloxone in our lab to do this. And what we'd see is that we precipitate these withdrawal behaviors, and we can monitor those withdrawal behaviors, and we can monitor how they change over this 3-day paradigm. So what we'd see is that typically you see what we call a sensitization of the withdrawal. The animals become have this increase in their withdrawal syndrome, and we think that's really important for the development of opioid use disorder. So when we decided to design this experiment, Madigan and I sat down and we said, okay, we definitely need a saline group for control. We definitely need a xylazine alone group. We definitely need a fentanyl group, and we need a fentanyl plus xylazine group. And our idea was that fentanyl plus xylazine was going to boost our withdrawal syndrome. And we thought we really wouldn't see a whole heck of a lot with xylazine by itself because we were precipitating withdrawal with naloxone. And since xylazine is supposed to act exclusively on alpha-2 adrenergic receptors, we didn't think naloxone was going to have any course of action that way. Boy, were we surprised. Why is this not? Oh, there we go. Okay. So, oh no, I went too far. Go back. Okay. So what we found, interestingly, in our female animals, xylazine alone these animals were going through withdrawal when they got naloxone administered. This was very, very surprising. We did see a little bit of this in our males. It was not nearly as potent, and it did not sensitize the same way that it did across the 3-day treatment period as it did with the females. We did also see that the xylazine fentanyl combo seemed to make things even worse in this situation, and that is perhaps not so surprising as well. But when the animals had naloxone after fentanyl and xylazine, it looked pretty much just the same as if they had just had fentanyl or if they had just had xylazine. Those were almost exactly the same. And in panel B, you can see that these are the withdrawal symptoms that were tabulated out individually, and it gives you a really nice color map representation. But things were looking really different again in the males and the females. And so this was something that was very, very interesting to us and very concerning. So the other thing that we thought here was they were like, okay, well, what's going on? So naloxone is supposed to only be bumping drug off of opioid receptors. It shouldn't probably be hitting adrenergic receptors. We don't really know if that's the case, yes or no right now, but this is where our mind was at the time. We thought, okay, well, xylazine could be doing a number of different things. It could be doing something signaling-wise intracellularly. It could be doing something where it's releasing endogenous opiates in some ways, and there is a little bit of evidence in the preclinical literature to suggest that as well. But we are so fortunate to have Brian Roth in the PDSP at UNC. So called Brian up and I said, can you screen this for us? And he said, sure. So we decided to run it against a very rapid test called Presto Tango that looks at over 300 G protein coupled receptors. And we got a really interesting hit out of that test, and that was the kappa opioid receptor. So we did a whole bunch more work, and I'm just showing you a little bit of that here today. But what we found was that xylazine indeed is binding kappa opioid receptors, and it's binding at a concentration that is frankly physiologically relevant. It's way right shifted from salvinorin A, but salvinorin A is one of the most potent selective drugs that you've got out there. So that's not to be unexpected. But we do have a Ki of 470 nanomolar, which I think is really, really relevant for us to consider and think about. There were some other interesting targets. This is a competition binding assay over on the right panel that we looked at. And I want you to pay attention to the sigma receptors that are over there on the right side of that right panel, because I'm going to be talking about them in just a minute here if I have enough time. Okay. So we wanted to test this back in the animals again. So we decided to look at a selective kappa antagonist. This is a drug called norbinai. So this drug should preferentially target that kappa opioid receptor. And so Madigan repeated these experiments. This time we did it a little bit different. We did 3 days of agonist treatment and then a single withdrawal, because norbinai is a very long lasting molecule. It's actually something that would be really interesting to think about as a potential therapeutic down the road. So we did this experiment a little bit differently, but again, we got some really, really interesting results and some really, really interesting sex difference results. So these are brand new data that are not in our preprint that came out a few weeks ago. What we found here is that the females seem to be much more sensitive to norbinai in general, whether they get fentanyl, xylazine, or fentanyl xylazine combined. But we are indeed seeing a precipitated withdrawal response to norbinai. Okay, so that is exciting. Moving back a little bit, I talked to you about that conditioned place preference. It's really important to understand reward. And the fact that we saw a little bit of a stimulus in those female animals when it came to the low dose of xylazine administration, we really wanted to look at this again and not use these really whopping concentrations. So here we kind of did a very similar experiment to this 2008 paper, but we shifted things a little bit so that we were just looking at fentanyl, xylazine, and the fentanyl-xylazine combination. And we used the same dosing strategy that we've used in our withdrawal studies as well. And interestingly, again, what we found in our male animals, they would show a conditioned place preference, so they would be able to tell us that they found fentanyl and fentanyl-xylazine combo rewarding, but there was no difference between how rewarding they essentially found fentanyl by itself or fentanyl-xylazine combo. However, the female animals were finding all three of these compounds rewarding at this dosage. So we have a whole lot more work to do with this. We want to look at a lot of different doses. We've got to do some very, very careful experiments, and we're going to repeat this because we want to do it a slightly different way as well. But I wanted to be able to share this data with you today because it's quite striking. Okay. So to get a little bit at some of the other things that we've been looking at, we're very interested in dexmedetomidine as well, and to see what it is doing as another emerging target in the drug supply. So we've been looking at this binding at these sigma receptors. These sigma receptors were initially identified as opioid receptors. They've kind of been reclassified as perhaps receptors that are partially helpful regulatory subunits for opioid receptors. But we're seeing some really interesting binding of xylazine and its metabolites to both sigma-1 and sigma-2. Now, interestingly, we don't see the dexmedetomidine binding to sigma-2 that we see to sigma-1. So that is something that we're still in the works, we're still figuring out. But again, it's this emerging data out of the lab that I wanted to share today. All of this data that I've shown you is not peer reviewed, so I want everyone to take everything with a grain of salt, but we felt for the public health crisis that we're in, we want to get our information disseminated as quickly as possible. Okay, so just to wrap up, what I showed you today in our preprint that's on bioarchivics is that low-dose xylazine stimulates locomotion in female mice. It exacerbates naloxone-precipitated withdrawal in female mice, but not male mice, and it has full agonist activity at kappa opioid receptors. The new data that I showed you today was that kappa opioid receptor antagonist, nor BNI, can also precipitate withdrawal from xylazine exclusively in female mice, but not male mice, and that low-dose xylazine promotes conditioned place preference, again, only in the female mice. We're finding that xylazine and its metabolites are having other binding partners, and that we are really interested in exploring those down the road. So thank you all for your attention and for my wonderful lab, fabulous contributors, our collaborators, and our funding mechanisms. Thank you.
Dr. McElliott, I feel like we just read your paper with you. Thank you. We do have time for just a couple of a question or two. Any question in the room wanting to follow up on that kind of fascinating, as we learn more and think about what we're learning. If I don't have a question, I'm going to give you one more minute to say what is it you might have wanted to say, but I didn't give you time.
Oh, you're great.
Go for it.
Oh, okay. Things that I really want to say. One of the things that has been sticking with us so much, and we've talked about it today, is that the question of naloxone and what is naloxone doing. And when we first started seeing, in the New England Journal of Medicine, coming out of literature from the White House and various politicians, is that naloxone doesn't work. Naloxone doesn't work. We don't know yet. And I really want to push back on that a little bit, that we don't know if naloxone isn't working. So I want to emphasize, especially for the public health side of things, and I am not a public health researcher, but please give people naloxone. So that's kind of my final thought on all of this right now. Thank you.
Yeah. All right. Thank you so much, Dr. McElliott. And I know there's great interest in your slides and just stimulating. And that's part of why we have this program, right, is to continue to learn more. So let's turn to our third presentation of the day. So we're going to turn back to an FDA perspective here, but from a different part of the agency. And Dr. Gonzalo Gamboa da Costa is the Senior Science Advisor at the National Center for Toxicological Research, which is part of FDA's Office of the Chief Scientist. So, Dr. Gamboa, tell us what this part of FDA is doing.
Thank you so much. Thank you for the invitation to speak here today and for all of those of you present here online. Yes, I mean, my intention is to provide a little bit to complement the presentation that our CEDAR colleague presented earlier on and expand a little bit on what else is happening at the FDA, namely at the National Center for Toxicological Research. As a way of background, it's the only center of the FDA that is not located in the DC area. We are located south of Little Rock, Arkansas, but we keep very, very close ties with our colleagues in the product centers, namely with CEDAR. So just a mandatory disclaimer. All right, so I will go very quickly over this. I mean, I cannot possibly provide a better background than those that our colleagues earlier on today provided, but I mean, xylazine was originally developed as a possible antihypertensive agent. It did not work for humans. Later on, approximately 10 years later, it was approved by the FDA as a non-opioid sedative and analgesic for veterinary use. And I mean, it has very broad use in that scope. And surprisingly, over 60 years later, we're finding that after all, this may actually be an opioid. So very interesting that the field is evolving fast. Importantly, there's no approved uses of xylazine for humans. All right, so sadly, and as you've seen earlier today, xylazine is being added to opioids. I mean, initially it was with heroin in Puerto Rico, and more recently it's been adding to fentanyl, primarily initially in Philadelphia, but it's expanding throughout the nation. Presumably, xylazine started being added to these opioids to lengthen the short duration of the fentanyl injection effects. All right, so focusing a little bit now on the main object of our research, and I apologize for the graphic nature of the image, but people need to understand what we're dealing with. So, it's well known by now that people who inject drugs and use combinations of fentanyl and xylazine tend to develop these necrotic ulcerations on the site of injection, but not only there. Elsewhere in the body, so it does not seem to be necessarily associated directly with the injection process, although there's anecdotal reports that missing the vein tends to predispose to the formation of these ulcerations. As was indicated earlier on today, there's further complications that arise from secondary infection of these wounds, which complicate things substantially. So what we see here is an example of an early lesion and an example of how bad things can quickly get. All right, so a really important piece of the here is that we don't truly understand how these lesions form. We have some sense that prolonged vasoconstriction and hypoxia due to exposure to xylazine may be involved here. We also know now from recent data from our colleague that just presented that perhaps binding to the kappa opioid receptor may also be involved in the mechanism that triggers these lesions. Part of the information that suggests that is that the pentazocine, another kappa opioid receptor agonist, also leads to the formation of comparable lesions. But what's clear is that the natural history of these lesions is really very poorly understood. And part of the reason for that is that typically people who inject drugs that develop these lesions do not seek immediate help. They only show up in the ER later on in the process when the lesions are very advanced. So what became clear to the FDA is that we need a model. And when I'm talking about a model here, I'm talking about an animal model. Because unfortunately, this is way too complex for us to cover in vitro. We need an animal model to investigate the mechanisms by which these skin lesions arise, and also create an opportunity to study possible clinical interventions to manage the lesions. Okay, so in order for you to have an appropriate model to study the natural history of these lesions and possible interventions, you need to have a number of things in place. You obviously need to have the receptors that may be involved with the mechanisms of toxicity represented in that model. You need to have an immune system can hopefully recapitulate steps that may be involved in this process. But really important, and this is perhaps this is the initial stage of the research that we are conducting, is that we need an animal model that recapitulates the metabolism of xylazine and fentanyl. And the reason why this is really important is that the animals, laboratory animals and humans, do not always metabolize drugs the same way. Actually, they can metabolize the drugs in a very dramatically different way. And so conclusions that you get from a model that metabolize differently from humans may not be informative of the human pathology. So, I mean, in the end of the day, depending upon how the animal metabolizes drugs, it may lead us to in the right path or in the wrong path. Okay, so what we are currently doing is we're currently conducting in vitro studies to understand how xylazine and fentanyl are metabolized in the human liver, as well as in the livers of a number of possible animal models that we are considering to then pursue research on the skin lesions. So the intent will be to select the most human relevant model. We want to cover biologic diversity. I mean, the example that we've just seen, that male and female rats respond differently to these drugs, is a good example. Whether it's associated with the metabolism or not, we don't know. But anyway, we want to cover that space. And importantly, I mean, this is a process that will allow us not only to move fast, but also to avoid using animals in an initial stage. I'm an experimentalist, and so we have not really seen that much level of detail about how the work is going to be done. But I wanted to just bring you a little bit up to speed on what we're doing. So the approach that we're taking is we're using extracts of liver from humans, as well as a number of laboratory species. I mean, I have here rats and mice represented. The intent is to incubate the drug, xylazine or fentanyl, or actually a combination. And then we're going to track, or we are tracking, how each metabolite evolves with time. So for example, I mean, this is just data that is a synthetic data, just to illustrate what we mean with selecting the best model. So let's imagine that we're looking at this given metabolite of xylazine, named metabolite X here, and we conclude that humans and rats are much more comparable when it comes to the metabolism of these metabolites. So this would suggest that at least when it comes to this metabolite, and if this is a metabolite that we think that may be involved in the mechanism of toxicity, that maybe mice would not be a good model. So this work is being done in my laboratory at NCTR. And another important aspect that we're covering here is trying to understand, and this has to do with toxicology of mixtures that can be remarkably complex to follow. We want to understand to what extent the metabolism of fentanyl or the metabolism of xylazine may impact one another. And this both in the human liver as well as in the liver of relevant laboratory species. And I mean, this goes towards our need to answer questions that go beyond just the skin lesions. I mean, as a colleague was asking earlier today, I mean, what happens internally? I mean, what other lesions may be arising? We need to understand that better. And so we need to understand which model we should be using for these. And finally, and very importantly, reversal agents. So one of the challenges we have reversal agents for xylazine in the veterinary space. What's unclear to us is to what extent some of these possible reversal agents may actually impair the clearance of fentanyl. So if we give a reversal agent for xylazine, but then we impair clearance of fentanyl, we are in a really complicated position, because the person will then not be able to get rid of fentanyl. And that can be very dangerous. So again, these are initial studies that we are conducting because they're fast, they can deliver fast responses, and they can guide us towards more substantive pharmacokinetic studies that can then inform work. And importantly, we're doing this in very, very close collaboration with our colleagues in CEDAR, because in the end of the day, we just generate the data that they can then use to inform their regulatory decisions. And so thank you for your attention.
So really helpful in helping us think through what is it that we can learn in the animal model and then apply that in humans. One of the questions that came in online was how do we and you talked a little bit about this, but just remind us, how do you think about that translation of the experience in an animal and then how that might relate to the experience in a human? You did a little bit of this on your slide, but I think just basically, would you remind us of that?
Certainly. So, I mean, it's a really good question, and it's always a challenge to translate animal data to humans. I mean, there are certain aspects of metabolism and processes of toxicological processes that are well translated between species. Others are not. They're more challenging here. But I mean, but as an example, so let's imagine that when it comes to these to the skin lesions, if we were to select an animal model that produced a different metabolic profile of xylazine than humans do, and conceivably the metabolites, but not xylazine, were mainly responsible for the induction of skin lesions, we would not be recapitulating what happens in humans. And so that the data that we generate would not be particularly useful. It's sort of a shift in paradigm. In the past, people tended to use rats because they were the default model. We would like to make sure that we're using the very best model that can recapitulate this. If it's a pig, it's a pig.
Great. And so you're trying to, so one of the ways you're controlling there is saying, let's see how close we can get to, in the animal model, the same metabolism process that we would see in the human.
Correct. Yeah. Metabolism being only the very first step. I mean, there's other considerations and receptors, etc.
Absolutely. Great. And so then as you're thinking about that, do you have a suggestion of species yet? Or
no, I mean, we have clues. I mean, we know that, for example, when it comes to recapitulating the properties of human skin, pigs tend to be a good model, for example. But there's more at play here. Again, I mean, first we need to, and pigs are one of the species that we are evaluating for metabolism. But yeah, I mean, really good question. We have some clues.
Still figuring it out. Yes.
Thank you.
All right, great. Thank you all. Let's thank Dr. Gamboa. Thank you so much for joining us. All right, rounding out our morning. Dr. Alex Krotulski is the Associate Director of Toxicology and Chemistry at the Center for Forensic Science and Research and Education. Dr. Krotulski, we're looking forward to hearing from you a little bit more in moving us into the clinical research space. So we've gotten a bit of a tour of the different ways we can look at this challenge, and I'm going to turn to you for the last stop on that tour for the morning.
Yes, thank you. Good morning, everyone. And yes, I am going to sort of focus more on the sort of forensic and clinical aspects, although I will provide some insights that we've gathered through our organization. So this is just an introductory slide to myself. I do work for an organization called the Center for Forensic Science Research and Education. We are a nonprofit forensic laboratory located right outside Philadelphia. We have partners and collaborators all over the country. So we have a quite interesting look into what's going on nationally. I do have a disclosure slide, and it's more of actually a sort of thank you slide. We have funding from a number of organizations, including the NIJ, CDC, NIH, and FDA. We've got a whole bunch of different research projects going on, and I can't really parse these out in the funding, so I just threw these all together and just want to show our appreciation for all of that funding. So to start off, I do just want to talk about our NPS discovery program, if you've never heard of it. So as I mentioned, I work for a laboratory called the Center for Forensic Science Research and Education. And in 2018, we launched a program called NPS Discovery. NPS Discovery is an open access drug early warning system. We really developed our model based on models that were present in other countries. I'll talk about some of the different aspects that go into our NPS Discovery program. But we'll really try to gain as much information as we can about drugs and adulterants from a number of different perspectives, whether it's public health or public safety perspectives, different scientific, medical, legal perspectives, really with the end goal to reduce harms. I always make sort of the example of everybody understands the early warning system we have for tornadoes, right? We're monitoring for whether or not tornadoes are going to touch down, and then we alert people. It's a little bit different. You're not going to get an alert when xylazine pops up in your area on your phone, like the national alert we'll have later today. But there are some similarities there. And again, really all early warning systems and drug early warning systems have the goal of reducing harms. All the data that we generate are generated in-house, and I'm going to walk you through some of our clinical research initiatives. We've got a whole bunch of other things going on as it relates to gathering intelligence about drugs, what's going on in drug supplies, surveilling various drug supplies to see what drugs are actually popping up and what we're seeing. We monitor and do a whole bunch of different testing on various sample populations. We respond. That's really important. Our goal, and I always tell people, we're an open book. Our laboratory is an open book. The data that we generate, we want to talk about. We don't want to keep it to ourselves. So we always want to respond. And then often, if we know where we've been, we do try to forecast and see where we're going. Sometimes though, that's a little bit more challenging. So this is just a really sort of simplified version of our NPS discovery program. But essentially what we do is we take all these different forms of information, whether it's pharmacological information and evaluations. We have a number of partners here in the United States and around the world that are doing pharmacological evaluations. We look at drug use forums. We work with medical examiners and coroners monitoring fatal overdoses. We surveil gray market sites. We do testing of impaired drivers. We do drug material testing, as you heard about this morning. And then really the piece I'm going to talk today is about the non-fatal overdoses. So I always tell people there's a number of things that can happen when people use drugs. The first is nothing could happen at all. The second is that they could have some sort of experience that does not result in any sort of medical attention. They could present to an emergency department. The fourth option, the worst option, is that they could end up in a medical examiner's office or coroner's office. So our goal is to make sure we are monitoring drugs and their impacts at all of those different levels. And that's really the goal of our program. All of our data does a whole bunch of different things. Sometimes we try to answer one question, and rather than answering that question, 5 more questions pop up. So sometimes our sort of data and results feed back into themselves. But our goal is really to share our information with a number of agencies, including a variety of federal agencies, more than just those that we're funded by, and share our information with folks around the world. So that was a really quick crash course into that. I'll just skip that slide. So I just wanted to talk a little bit about the data that we have on the xylazine situation in the United States. So through our forensic toxicology surveillance, as you've all seen and all probably know, the positivity of xylazine does continue to increase in the United States. We will have our Q3 data here available within the next week, and I do expect that number to likely increase. In a collaboration that the CFSRE has with NMS Labs, we've been able to look at the geographical distribution and change of xylazine prevalence across the country. So you can see there Q1 of 2019 through Q4 of 2022. And you can see that you've got more states that are colored in and more darker states, meaning that xylazine's prevalence certainly is increasing. And I just want to mention there that data is not a complete data set. Just because a state's not filled in doesn't mean that there's no xylazine there. It's just based on the data that comes from NMS Labs and their toxicology testing. Some have alluded to what's happening in the Philadelphia drug supply. This is just 2 different examples of what's going on. The first on the left is opioid or dope samples that contain xylazine. You can see we are nearing almost all fentanyl samples in Philadelphia containing xylazine. And then on the right there, that is the content or purity of xylazine in these samples. So the first thing you'll notice is that the dots are all over the place, and that is true. There's a huge variability in the amount of xylazine that's in the supply in Philadelphia. But you'll notice based on the line that the average is increasing. We are seeing an increasing trend in that amount of xylazine. And just to answer one of the questions that had come up earlier, we have looked at the correlation between fentanyl and xylazine content in samples from Philadelphia, and there is no correlation. There is no rising correlation, decreasing correlation. It really is all over the map. If you look at the fentanyl graphic, it looks just like this as well. There's huge variability in all of this. There's really not much you can sort of assume based on yesterday or the week prior. So this gets to what are some of the unanswered questions, and I think a lot of the speakers today have alluded to this. There's a lot of unanswered questions that we have. While we may know some of the sources of where xylazine may originate, we don't necessarily know where the xylazine in a specific sample has come from. We don't know how much xylazine humans are consuming. while we're gathering quantitative data, as Tracy Green talked about earlier, people may be using 1 bag, 2 bags, 15 bags in a day. We don't have a good sense of how much xylazine people are consuming. And certainly, as Tracy alluded to, the data looks different in New England as it does in Philadelphia. We don't know what the pharmacokinetic profile truly looks like in humans. We don't have a good half-life. We don't really know if that's affected by co-ingestion, which was just previously mentioned. We don't necessarily, so we know how xylazine can be metabolized, but we don't actually know what the primary metabolites are that we expect to see in different biological specimens, and then what the significance of those metabolites are. We don't know how much xylazine is circulating in blood in certain scenarios. We're gathering some of this data. I'm actually going to talk about this. And then lastly, really the goal here is to, at least as part of this clinical focused session, is really trying to figure out what the best clinical practice is for patients who are presenting after xylazine exposure. We're hearing different things from ED physicians and doctors across the country, and trying to get to a place of maybe standardizing more of that, sharing that information is really the goal of the clinical collaborators that we work with. So as you probably have already figured out, I am not a medical doctor. I do not see patients in the ED. I am a forensic toxicologist who works in a lab. So certainly the expertise on that comes from my colleagues. So here's some of the things that we're doing. And this is all going on in real time. So some of these things I don't have answers to yet, but we will have answers as time goes on. We are currently testing for a number of drugs in toxicology samples. So we're currently quantifying fentanyl, xylazine, cocaine, methamphetamine, naloxone, and some other drugs in blood that's collected from patients who are presenting to emergency departments. We do have some interest in expanding that method to look at various xylazine metabolites. However, first, we need to know what to expect and how much of those to expect in samples. We can't develop an assay, a quantitative assay, without knowing really what our target concentration should be. So we've got some studies going on, one of which that's, again, evaluating quantitative data of xylazine in blood. I'll show some of those cases a little bit later. We're trying to embark on some pharmacokinetic studies, whether those be in animal models or human models or humans. And then trying to tie some of the clinical findings with our toxicology results. We are doing in vitro characterization of xylazine metabolism. You've seen this figure already in the last presentation. So again, the metabolites of xylazine are known. We just don't know exactly how much or what to expect in blood versus urine in these patients that are presenting to emergency departments. And then is it different for patients who are overdosing and ending up in medical examiners' offices? So we're doing some studies now. We did a characterization of xylazine metabolites in urine. We got about 400 urine samples from Philadelphia, and we had about an 88% positivity for xylazine, which isn't surprising based on the numbers you've heard about and the data you've heard about from Philadelphia. And the one thing I can say is that xylazine does remain, from a toxicological perspective, xylazine itself remains a good biomarker in urine. We're finding xylazine in all these samples. We are seeing, though, different levels of these metabolites, and again, just trying to figure this out. And obviously, the situation in Philadelphia is a little bit different. A lot more xylazine is being consumed in Philadelphia than is being consumed in New England, or even in other places around the country. We've got a number of different clinical efforts going on. We have a collaboration with the American College of Medical Toxicologists. They have a number of sites across the country who are sending samples to us as part of a variety of different studies, looking at really trying to figure out what drugs are present in people's systems as they're presenting to emergency departments. From that, we've been able to see where we are and aren't detecting xylazine. So this mimics kind of our forensic data. You can see that if you were to paint a grayscale from east to west in the United States, with the darkest in the east and the lightest in the west, that's kind of how this looks as you move west. Oops. There was a recent study, and I don't have time to go into this too much in detail, but ACMT launched a study looking at patients who had xylazine confirmed in their plasma or serum after presenting to emergency departments, and found that patients who had xylazine present had significantly lower odds of cardiac arrest and coma. So the results there would suggest there's some sort of like protectiveness going on with xylazine. However, I would caution that we're doing more research here to figure out, is there sort of a concentration dependence here? Was the fentanyl amount lower or not? It certainly doesn't answer the question, but certainly an interesting finding. And it's obviously not the biggest cohort. We are collecting many, many more samples to continue evaluating this. And these, I don't have time to go through all these, so I'm actually probably just going to go through these quickly, but I will make these slides available. They are available on our website, cfsre.org, under our resource section. But these are just different cases from our study with Kavita Babu and her team up at UMass Chan Medical School in Massachusetts. And I picked out 4 different cases, 2 cases that have xylazine, 2 cases that do not have xylazine, and then 2 cases that have stimulants and 2 cases that do not have stimulants, and those are every other with the xylazine case, if that makes sense. So here you can see a case with fentanyl, norfentanyl, methamphetamine, cocaine, xylazine, and you can see the quantitative data there. This case has fentanyl, a very small amount of cocaine and xylazine. This case has fentanyl and just stimulants, and then this last case is just fentanyl. And there was actually a decent amount of ethanol in that case. Really the whole thing I wanted to paint with all of these, and I don't have, again, time to go through all this, but this is really challenging from a clinical perspective. We have to go about this case by case. We have hundreds and hundreds of patients that are being processed through this research initiative, and it's very difficult. You can't just apply criteria and say, okay, well, let's just apply that criteria to all patients. We actually have to go through and analyze this case by case, so it takes a very long time. There's a high co-occurrence in these cases of multiple drugs. That's kind of the common phenomenon in forensic and clinical toxicology right now. It's very, very rare to find an individual who's experiencing an overdose that only has one substance on board, whether that be one drug or one adulterant. There's certainly a lot of unknown factors that we don't know about, and are trying to figure out how we can add them into the work that we're doing, understanding things like tolerance and understanding things like dose. How much did someone use, and can we eventually get there? And really the take-home message there is that a lot of that is very complex. So to wrap this up, where to from here? Obviously, there's a lot of research that still needs to be done. I would argue that we don't know more than we know right now about xylazine and what's going on in the recreational drug supply. And unfortunately, that will probably always be that way. The recreational drug supply, as you've heard, is extremely volatile, extremely dynamic. I'm not sure we'll ever be ahead of that. From a research perspective, there's just not enough of us scientists in the United States to do all that work. Cross-field collaborations, I believe, will be the most successful. You've heard of a lot of successful stories in the research realm here today already, and I do believe that's true. In my opinion, the good news is that there's increased awareness and attention and funding happening as it relates to xylazine. But in my opinion, the bad news is that maybe this is a little bit too late. You heard from Philadelphia. Xylazine first emerged in Philadelphia in 2006, or around that time. It's been more than a decade, almost 2 decades, and we haven't been as vigilant about this until now. So I would argue that we may have missed the ball on this. The other thing I would like to bring up too is while we're here today talking a lot about xylazine, and you've heard about medetomidine, the thing that we're not evaluating is what are the other adulterants that are found with fentanyl. So there's a reason why we find xylazine with fentanyl, and it's to make the high and the experience someone feels from fentanyl better. It's not just xylazine that's being adulterated into fentanyl. It's these benzodiazepines, things like bromazolam, it's quetiapine. You're hearing a lot about the East Coast and the Mid-Atlantic, the Northeastern United States. We're not hearing a lot about the Midwest. There's a lot going on in the Midwest as it relates to bromazolam and fentanyl, these sort of benzodope combinations. If xylazine does in fact go away, you can expect to see more of those benzodope combinations. So I just want to kind of put that on everyone's radar, that there is more out there. I know that's kind of like a pessimistic view on it, but that's that. And yeah, I know that I took up more of the time than I was allotted. Oh, just lastly, I would like to acknowledge, I often say that it takes an army. I do not do this alone. I have a lot of collaborators and a lot of folks back in the lab that I could not do this without, and certainly we couldn't do this without our funding partner. So that's
awesome. Thank you, Dr. Katulski. I've got 2 questions for you, so 2 quick questions for you. One, are you doing any work to examine the correlations between law enforcement actions like confiscations and drug busts and fluctuations in the drug supply?
We are trying, but I will say right now it's difficult. The drug checking data that we're getting is on the week to month time frame. The law enforcement data that we get is on the months to year time frame. So if I want to compare our drug checking data with law enforcement data, I may have to do that 12 months after something. So if I want to compare data now, if I can't do that until Q4 of 2024, it's really not helpful right now. So while we do, and a lot of us do try to compare that data, the timelines just don't match up. So in scenarios where the crime lab data is extremely rapid and we have that information, it is good to compare, but it is challenging.
Yep. And then this one relates to something that many of the speakers talked about the xylazine metabolites. Do we need to know anything about the metabolite toxicity, or does that go in that bucket of what I think you said, there's more that we don't know than that we do know?
Yeah, so I mean, there's a lot of emerging research going on right now evaluating xylazine's metabolites. So I want to say that I haven't read enough of it, again, because it's so emerging to have like a concrete answer. I do know that there still are a lot of questions. One of the things that we hope to gain from a pharmacokinetic study is tracking these metabolite profiles. And if we're going to track the metabolite profiles, then we want to know things like, well, what are the activity and toxicity of these metabolites, and where are they of concern biologically and pharmacologically? So, so the answer is that some of that is kind of happening right now in real time, and hopefully in the next few months or year, we'll have answers on that. The challenge, though, is that research doesn't happen overnight. The things that we get up here and talk about have been sometimes months and years in the works, so it's hard.
And presented in 9 to 11 minutes, which
Yes.
is what's impressive. So let's thank all of our speakers for session 2. Just really informative, and then we know there are some other things coming through on the horizon. So thanks to all of them for joining us. We are now at our 1 hour break.